Very good morning, everyone. On behalf of IIP Navi Mumbai, I welcome you all to this most awaited CME, Monsoon Maladies. Year after year, we keep this CME to help all of us to understand monsoon illnesses, to discuss the challenges faced in our practice, and clear all our doubts so that we can take care of our patients in a much better and in the correct way. We are extremely fortunate to have a wonderful mix of our own Navi Mumbai experts from around Navi Mumbai, from Maharashtra, and also Dr. Fernando, an international expert from Sri Lanka, who will be joining us online. I'm sure it is going to be a meaningful learning worth every minute today. We have curated the scientific agenda to include all monsoon related cases that we commonly face, and we also have two panels. One panel discussing the common OPD scenario, and the other panel discussing serious complications that we face in ICU and our wards. To allow clearing of doubts and interaction after each session, we have two expert moderators who will be discussing the audience doubts and also taking Q&A with our experts. One of these moderators is an expert, experienced pediatrician, Dr. Asmita Patil, and the other needs no introduction, our own Navi Mumbai ID specialist, Dr. Dhanya Dharmapalan. Dr. Dhanya also helped in planning and curating the scientific session for today's CNE. Thank you, Dr. Dhanya. But before we begin our CNE, let us remember a legend who left us yesterday, a great teacher, a passionate doctor, a true genius, whose talks would amaze all of us. But most importantly, I feel his talks would make us think that what more could be done and would actually make us wonder what all is still left to be done. And even till his very last few days, he kept working towards it. Dr. Merchant, you will always remain in our hearts. I request all of you to observe a moment's silence for sir. As we will be during this CME, this journey on earth on this lifetime is getting over. But I think his teachings will carry on for years to come and we will remember them always. I now request our moderator, Dr. Asmita, to take over. Good morning, everyone. A warm welcome to each one of you on this wonderful Sunday morning. I think Navi Mumbai has set this train to do this semi every year so that all pediatricians remain updated about the guidelines how to manage patient in this monsoon period. The Already season has started. I'm sure everyone's OPD is going very busy. So all everything is started. The flu, the common cold, the cough, measles, dengue, and many cases of malaria are coming. And during this busy OPD, it is very important to know and identify which patient requires little more extra care, how to identify danger signs, and how to go about when we see a patient in the OPD. So let us have this journey through the case-based approach, and I will invite Dr. Yeble sir to moderate this session to take us through this how to deal with the flooded OPD in the monsoon season. Sir is mentor to every one of us. Sir needs no introduction, and I also welcome the panelists for the sessions. Dr. Sridhar sir will join later. Dr. Jitendra Gawane sir, our past president LP and Central LP member. Dr. Satish Rane sir, past president Mumbai LP. And Dr. Madhuri Iyer madam, senior pediatrician in NMMC hospital and head of the department. I request, I request sir to take for the session.
Good morning and nice to see Cyber member in the hall early morning. I was early morning until evening since morning. And I was asked to moderate something like this. When the gray cloud gather, then the gray clouds are burst and then it gives volume some small and happens in the uh, living side of the and managing the credit opening also. That actually the season has begun and all of us are experiencing the period. I had a word with Atul who came from Solar. He also has been keeping with the actually from the OPD he directly jumped to the train and has been kind enough to travel to the Navu with us today. So we have an esteemed panel of experts from Navi Mumbai who have been managing this monsoon maladies for years. And let's see what are the new things, how best we can rationalize our practices during monsoon. So basically, managing flooded OPD, I believe, is not managing this kind of flooded OPD, but something like this. So this is something where we have no role to play. And but yes, let's see what how best we can handle our patients during such crowded OPD, which I'm sure most of us are flooded OPD. So what happens during monsoon is basically we see higher numbers. There are higher numbers of patients coming without the अभी फिगर आया आपका 103 ताप है डॉक्टर आपका देखो जर 5 मिनट का काम का करना होता है तो वगैरह and this can really upset your schedule and so one needs to be a little more punctual during monsoon than any other time and start the OPD on time so that you can the time given to patient is not compromised and then there are very important epidemiological cues. We know the monsoon maladies or illnesses which cluster during monsoon months. And these cues definitely influence your thoughts and the way you analyze the given case. And it very often impacts your differentials that you think of and you change the differential. If, for example, a child coming out of monsoon during summer with high fever, one wouldn't think of dengue or influenza. But is the other way around such a patient going to monsoon? Of course, there are a few illnesses which are seen around the year, and we'll touch upon a few of them. And it definitely impacts the threshold for doing labs, and then the threshold for admitting patients also gets influenced by this ADOPD and the kind of presentation that these patients present to us with. And but at the same time, let's not forget that non-monsoon related illness also come during monsoon. And let's not have a tubular vision and let's keep our minds open and not forget the deep differences as well when a patient walks into the OPD. So with this introductory remarks, let's begin with what we actually see in day-to-day practice. And what I have done, I have put up some cases. I saw the note about a week ago, and Mangi called me that this is what is being planned. And then I thought, let me start jotting down what I see from Monday onwards. So Monday when I went to the open, this is the first patient I saw. 18-month-old girl, fever for a day, which was mild. That was it not crossing 100. And the child has had loose stools since the previous night. About 8 to 10 small quantity. This is almost every hour she goes, 2, 3 times in an hour. And these stools are sticky, like phlegm. This was her description. I asked her if there was blood in the stool. No. And then the mother said the baby has pain in tummy. I said, how do you know? She's been crying and she's holding on to her thigh. And off late, we know that about a couple of months ago, we had a lot of cases of viral diarrhea. And we do see a lot of travel diarrhea around it's vacation time and the patients start coming back. So with this background, I can let me ask Madhvi, what thoughts cross your mind and what do you keep in mind? Small quantity of stools, child has little abdominal discomfort, mucus, no gross blood of course. So what would your diagnosis be? Is it a viral diarrhea that I'm giving, or would you call it dysentery, or could this be a parasitic? In the 18 months in the time the child starts crawling, putting everything and everything is out. And how do you handle this patient?
As fever is around 800, the child is not in between the fever spikes slightly. Otherwise, mother is not bothered about her urine output or otherwise sick looking child. So probably I am dealing with only viral kind of picture in which loose stools right now to begin with is a prodrome. Maybe after a couple of days the child will end up with cough cold as well. There is no blood in the stool, so I'm very sure that I may not have all the antibiotics because it is not vascular recently. And probably with the colicky pain, it is a part and parcel of our diarrhea. So we need to convince mother that there is absolutely no load of antibiotic as of now. ORS should be the first thing. And we need to at the same time tell mother what are the warning signs to keep on seeing the activity of the child and how the urine output is, how the child is with the fever spikes, and keep on engaging her to give small multiple treatment days as the appetite might go down. So zinc, ORS, and probiotic for parents' satisfaction. Absolutely no load of antibiotic. We ask the parents to come back with the etiquette signs and
In the role of metronidazole?
no.
No. Any disagreement among the other families?
The future treatment of diarrhea is ORS and zinc. So zinc should be given in proper dose, which is not functioning. And as Madhvi said, probiotic is also not evidence based. So plus minus for parents stay with you. Otherwise, there is a scientifically only no evidence of helping actual watching diarrhea.
Fine. So let's take it home very clear that most of the under 5 diarrheas are viral. But then I have put up this case specifically to highlight that mother says viral diarrhea are usually watery diarrhea and they are voluminous diarrhea. But I mean, mother says the baby is passing very little stools, and it is mucoid, mucus stool. Though there is no blood, would you have a very low threshold in thinking of starting this child on an antibiotic, thinking of a bacillus dysentery, or maybe a parasitic infection? Okay, before you answer, let me tell you that last 2 months or so, we did see little older children coming with recently no frank blood, but cranky pain and mucus. And some of these children, we had to use Danya would, where is Danya? So we did use metronidazole on two patients. So would your threshold be letting go? Would you call this child very closely and start an antibiotic at appropriate time? Or an antiparasite.
Usually, the parasitic immunity is usually very finest. But if the whatever is like in the community, the outbreak is there because of some conversion. So with upfront, we can start with the this kind of patient, we are sure about the cramps are significant and the child may reduce also or small in weak one like I had the kind of a stool is not very violent. The violent area should have some at least component water stools or maybe we have some cough and cold around with the fever.
Yeah, so absolutely. I mean, let's not jump to giving antiparasitic or antibiotic to such children. Most of them are viral, so under 5 diarrhea, most of them are viral. Mucus or a few pustules does not necessarily mean bacillus dysentery. And often you do come across another condition.
Which patients we see on a weekly basis. and fever persistent, then in the IPD we have to add metro in a couple of times.
So now my question, having said that, you say this will come back, fever persist, welcome Parman. And so is the fever that is it taken as a criteria to add an antibiotic or antiviral?
No, not really, but how much ever we tell the parents, some parents are not at all getting convinced. So the criteria for admission from patient's point of view in terms of decreased oral intake, dehydration is altogether different. But such kind of patients who keep on coming recurrently, then probably with the general hospital, I may keep on admitting such patients after seeing CQC and then the mucoid fluid and crampy abdomen, then we admit.
Point well put by Marvi, but however, I mean, let's have a very high threshold for starting any antibiotic or antiviral, especially in such a young child. But I agree with that at times you do follow these patients up. They keep boggling with crampy abdominal pain. And it may so happen that a day or two down the course, the child starts starting crampy.
Only condition where we take low threshold for starting antibiotic and then we decelerating or stopping antibiotic is a grade 4 malnourished child, where we need to start and do septic workup and then only acute watery diarrhea can come in a sepsis also in grade 4.
Absolutely. Absolutely. So let me ask the audience, how many of you give zinc to each and every patient that comes from a higher socioeconomic strata? Yeah. So WHO has a strong recommendation, but then I have seen in practice, zinc is really, some children do not tolerate it. It's really nauseating at times. So, yes, ideally, there is a universal recommendation. And what is good in the interest of the community by and large is good for an individual patient also. So, whenever possible, physical and
Since patients are what sit on our head, what will be the stool routine and convincing and
I actually do not do solution unless
after
I
2
would
days,
prefer after
not on the first day.
I mean, what happens usually unless school routine is asked for, it shows pus cells, which is a normal occurrence, and then cefixime is given. Unfortunately, even today, a lot of pediatricians use cefixime for IPR. So, and all of us know, I mean, harm done by cefixime. It washes away the flora and then the diarrhea, which otherwise would come under treatment of fluid resistant infection for a week. And then, I mean, let's get out. I'm very happy that none of these pediatricians are pretty much rational and we don't indulge in such kind of practice. But occasionally, you do come across patients where septic film is done, stool routine is asked for, stool culture is asked for at times. And
The patient, especially upper class, they take Roco and O2M syrup and then they'll end up.
so, but I must admit that over a period of time, that combination prescription has gone down. Otherwise, non-metrogyl
And I want you to tell everyone, how do you convince about the regulation of diarrhea? Your patient gets convinced, but so we end up prescribing something.
I brought in my word that
Cloud.
I really
Yeah.
I tell you like many times you have stomatitis or COVID of your intestinal lining gets inflamed. And otherwise also routinely there is a constant wear and tear where the lining is replaced. Here the entire lining is removed and then it takes a little time. So have patients what is in your hand just to prevent dehydration. One, replacing what the child is using with extra liquids over and above what the child requires for his day-to-day maintenance. And then wait and watch, give dahi and buttermilk, which also has probiotic effect like what you prescribe. And then I tell them that the Aperilla, strong Aperilla, atomically you are zinc. So this is how I counsel my parents. I don't know if there is anything else that any other tip you can share with all our Ravi.
Basically, what I tell them is any flu-like illness, fever subsides when you do this reported, but in weakness and lack of it takes a bit more time. Similarly, like viruses will dissipate 3 4 days, but the digestion improvement will take some time. On average, 4 5 days, 30% will take more than 7 days.
And the moment you say there is a survey and I mean, I'm there to come out of it. And I've heard of pediatricians saying that they hope to, it's a way of washing them out. So, jokes apart. Let's go on to the second case that I saw on Monday. This is a 7-year-old fever since morning of 100. That was Monday morning. And this child had fever on Friday. There was no fever on Saturday and Sunday. I must tell you that you must immediately parents to the code and extract that details of fever. And that gives you your clinical diagnosis more often than not. And it's not so difficult to tease out infections requiring an antibiotic and infections which are non-bacterial. So let's do that exercise very rigorously. So this child had fever on Friday, no fever on Saturday and Sunday. Physical exam is normal. Temperature might be made was fever, but Satish, this child has biophysical kind of fever for a day, no fever in between, and then again fever. And I'm sure this is a extremely common occurrence, whether you are monsoon or summer or winter. This pattern has been there for last ages. And even when I started practicing, I was thinking that. We know that typical biophysical fever is dengue. But how do you explain this and what? I mean, do you suspect dengue in such a patient? And what it is?
So first of all, when child coming with fever, the people say degree of fever at the onset of the illness.
Good night.
Degree of fever at the onset of the illness. Second, interview the period when the child plays. Third is the child will appreciate complaints and I would say significant symptoms. And fourth, the child responding to the paracetamol means whether it's going to respond to plain paracetamol is not able to get respond to the plain paracetamol. It will give some idea. But there is a viability which will give aspect because sometimes clients they do listen to you till feel supported and then clients subside the fever they're fine. But if the second phase starts, they again get irritated because they say, "अभी तो बोला था fever जाएगा, चला गया अभी वापस आएगा." In these cases, we need to explain only these two things we need to see. The child need not appear other complaints like in cases of IPD fever, if they will have some weakness or body pain or significant myalgia. Or in cases of human pain, the fever does not respond to the paracetamol. So the inflammatory fever usually can come in the second phase, but where the child will have some associated other complaints also. Secondary vaccination as prescribed by the pediatrician families, but in place. Usually commonly seen after the like illness, especially by the locus. And sometimes with the dengue, we can get secondary infection with the child that got some underlying illnesses. So I would still wait for another 24 to 48 hours, see the pattern of fever. If it is really having significant impact on the physical body of the child or the I would say the nature of his playfulness, investigate this child and find out what kind of impression they are dealing with.
In some of you in such spaces where you have fever occurring cases, you have fever, no fever in between. You, however rational you are, the patient comes for the second time, it tests your patience and confidence, and then you tend to alter and prescribe an equivalent. But finally, this is an extremely common presentation of a common garden variety viral infection. I'm not talking about the typical bacterial cases that one should daily, but this type of presentation is extremely common. And stay put, those who are those who started at what is not so cruel that with every small little viral infection you have secondary activation. Under that, it is to start an antibiotic. You overall look at the child's activity, and as Satish said very correctly, these 4 or 5 questions are definitely there. The golden questions, I would say, they give you an answer, degree of fever at onset, response to paracetamol, interfebrile period, activity in between the fever and other ways of the child, and the trend of the fever. That helps you a lot. And second phase, after being afebrile, is not uncommon in common viral infection, should be treated as second bacterial infection. So let us adhere to the standard practices. Of course, in monsoon months, your threshold or your index of suspicion for dengue should be very high. And as Satish very correctly mentioned, we would look out for other signs or symptoms which may indicate a leaky phase. The typical saddleback fever that one gets in dengue, you may not see in practice. A patient may present with fever of 24 days and fever goes down and you start seeing this kind of a pattern. We'll discuss that a little more in detail as we move on. So this is the third thing that I saw. A 13-year-old boy, high fever, 100 degrees this morning. Monday morning, the child came with high fever, little bit of cough, had fever for 1 day, 4 days ago. That's the type of 1 day, 4 days ago. And there's a little bit of flushing. Throat was mildly congested. G2. Now, what are the possibilities that would enter into this coming monsoon, I mean, you all of the, are you all seeing a lot of influenza?
Yes, yes.
Daily influenza is more than daily this way. And I think Atul, you could the same thing. Solapur also did not say much daily, but more of influenza. So what are the possibilities here? Do I admit this child? Do I run a few tests to arrive at a diagnosis? And what do I tell the patient? And how do I counsel? And do I really watch? And what do I tell the parents?
So this is the third OPD case which is coming to English Hospital, and me, Satish, and Vivi, Suhas, everyone has worked under you and seen this kind of OPD. The second picture what you showed, that was a typical scenario. And we used to have a lot of IPDs also that time. And before child becomes our also, blood, we used to call the micro lab and it is negative. And we were discharging also them very prematurely, kind of, because there was no place to admit a real genuine patient also. So that was a kind of Achedin.
Very important for Madhvi. Madhvi public health systems are overwhelmed with patients
Yes.
who do not deserve admissions, and then you don't have bed for patients who really deserve it. Yeah.
Yeah.
So it's not deserving patient, it is more deserving patient
I
who
know.
have been denied admission for lack of.
That's a whole public health flaw in our country.
Yeah.
The
So-
population that, yeah. Anyway,
Satish used to call that scenario as an hour of model where before finishing the patient used to say finish or finish. Yeah, so that was a I remember those days, and this is also like a 13-year boy with high grade fever to start with, and then he was off the bed. He had
some respiratory symptoms.
Yeah. So, mild flushing is common in any viral illness, not just dengue. So, mild flushing indicates that we need to monitor this patient well, and in OPD, there is no need of admitting this child, but definitely this warrants taking upfront the parents about the warnings and when we should come if the child is little weak and lethargic and passing less urine and not drinking enough oral liquids. Enough oral liquids is one indicator that if he hydrates himself well and passes urine well, then even if flushing is there, nothing will happen, and no need to do tests or no need to look at even if it is a dengue season, or just monitoring and calling him when so little deviation from normal trend. If he has experience, then immediately come again for checkup. That needs to be taken to the parent, and I think I will watch for this case and will not do rush for anything. Dengue is possible in this time. Typhoid also can have this kind of fever, but I will wait.
What would the influenza thing?
Influenza definitely is
There's a
a
lot of influenza we are seeing. Right? If I tell you that there are a lot of cases of influenza in the background, so would your threshold like to go for labeling this as influenza?
definitely, sir. But again, as I said, we should do the test only when we want to intervene in some fashion. So if you are telling warnings and even if it's influenza is taking rest at home and other things are not coming, I will still be okay with it.
So this kind of system is not uncommon. See, the dengue that we have seen over a period of time, the first contact getting what is called as primary infection in very young children who present like URI kind of an illness, requiring like till one more here and then fever. It is the older children who would come with typical primary dengue fever, backache, body pain, and then loss of appetite. They have suffused conjunctiva at times, and then they have recovered vital peak. It is the older children and adolescents who call as primary dengue. But as very rightly stated in all the guidelines, every fever, even during endemicity, should be taken as dengue unless proved otherwise. Because early diagnosis and very easy prompt treatment could see the child through without any complication. Secondly, flushing. Bandage is very common in viral illnesses. It is not pathognomonic of flu or dengue. And at times there can be a little overlap and one needs to entertain both influenza as well as dengue. Though influenza can come with only fever, many of these patients have some respiratory symptoms like cold, itchy throat or throat pain, little bit of cough here and there. And as GP, we will end up testing each and every patient. So flushing is just of a viral illness. Think of dengue fever, every acute fever illness in monsoon. Include the cases around, it is an extremely important thing. Last 15 days or more than that, we have started seeing lots of influenza cases. And that category, which was put forth in year 2009 with H1N1 family, still holds true. You have patients who use wait and watch, don't test, don't treat. There are a few patients where you test and treat, and there are patients who are critically you go ahead and treat the patient. Not forgetting that what we do in our practice is on basis, we are treating a patient of influenza, suspected influenza. We don't ask for PCR. And PCR again has its own limitation. One is cost, second thing is it is not 100% sensitive. So it really does not influence your decision to treat or not to treat. If you have a patient who has a negative influenza, but still you go ahead and then I would agree with me that there are good patients where influenza test has been negative, but on clinical suspicion or clinical diagnosis, we have treated such patients. And the moment you give anti-flu medicine, which you have breakdown in 30 hours in subsequent. So, OPD patients, no testing, have a low threshold, think of influenza will be cases going on in the background. And admitted patient, of course, if the resources permit, ask for an influenza test. But let it not be the sole guiding factor to start or discontinue treatment.
So at this point, I want to ask you a basic reality check. This child is 12 years and our guidelines says till 5 years we give influenza vaccine yearly for everyone. And what we have seen is those who are beyond 5 years also, if we are giving them and they are, even if they, the vaccine efficacy is only 50 to 60%, but even if we are giving them, the severity of the illness of they landing in ICU is very less. What is your experience?
So in IIP's committee's eyes, influenza vaccine has gone through a variety of different phases. Initially, it was a vaccine which was used in special situation, then one-to-one discussion, and then finally the ACWP came out with a guideline that this is a must for children below age of 12. Why so? We look at the meta-analysis and systematic reviews. It is in this young children below 2 years and 5 years that the risk of complicated illness or child getting hospitalized or developing allergy and having morbidity is very high. So IIT came out with a very strong recommendation to use this as a routine vaccine in children below age of 5 years. If you recall, in 2009, ICMR put up a guideline that influenza vaccine should be used up to the age of 9 years. And in my practice, at least I offer it to each and every child. Not uncommon, we have seen even older children coming with a low respiratory infection. It is an illness which can be prevented. Gone are the days when influenza vaccine was not freely available. The only drawback that it had is an annual vaccine, on which to have the efficacy or the preventive effectiveness would depend on it's a game of match and mismatch. If you have the right match, then the efficacy is extremely good. Otherwise, can be as low as 20% and 30%. So we do come across patients who have taken influenza vaccine but still suffer from children. I at least recommend, and even the IPC, be liberal. You don't have to be so rigid. Tomorrow, suppose a 14-year-old boy and the parents come and ask you, should I be taking influenza vaccine? Please don't do it. At least I offer it to each and every. So what is the practice that is followed in that? Are you all using influenza vaccine?
Yes.
Southern, northern hemispheric, that discussion is beyond this talk.
What you are still with us now? Only like that.
And of course, Japanese interpreters started with this. So IIT has lowered its threshold, be liberal. Okay, 12-year-old boy, fever since a day, and fever for 4 days, April for a day, fever again since 24 hours. Again, that pattern of fever, April, headache. Child is feeling weak. Fever of 2 centimeters, fever of 1 centimeter. No match. Now, Madhya, I'm sure most of the acute febrile illnesses in children, especially with fever very high, majority of them are viral. And all acute febrile illnesses are exhausting. And with the threshold would vary from child to child. And from parents to parents. Some parents are overprotective and they say, because now, what differentials you entertain, how do you prioritize, how do you investigate such a child? You have hepatosplenomegaly, child has had viral kind of a fever pattern. Now, this is a dilemma that is not an uncommon. Clinically, while you looking like picture, you have hepatosmegaly, would you ask for a blood culture? What differentials you will keep in mind? How will you manage?
Now, this child has already had fever for 4 days, as typical viral prodrome now was supposed to get over. With fever and prodromal symptoms again persisting is a red flag sign as against the previous case where there was only fever for 1 day and the parents had come to us being anxious. Important is dengue is also a virus and dengue is a hepatotropic virus. So clinically, even in the first case when we were talking about our mucous membrane like posterior pharyngeal wall was being inflamed, but if at the same time, if there would have been like hepatoconflict, tenderness or kind of condition that would again clinically point out to something going wrong with hepatotropic things in which during monsoon period dengue will come higher in the list. Spleen is palpable, they are endemic area for malaria, so we will again take malaria as a second differential diagnosis. The patients coming from which strata lecto will again stay as one of the differential diagnoses, though lower on the list with without myalgia and other complaints being there. And another click entry will always remain one of the differential diagnoses. So this patient will definitely get admitted because it is more than 4 days and we need to have a good workup. We cannot keep on asking the patient coming back and going again and he is feeling weak. Probably IV fluids will be required. As we said, the CBC would be helping us to differentiate about what kind of picture with eosinopenia, probably entry will be higher on the list and accordingly. Blood culture is definitely yes. I will admit the patient, give supportive line of treatment and do not harm immediately on starting the antibiotic. The reports are available in our city in around 4 to 5 weeks, which will give us an idea about it is definitely bacterial or not. So that is how I will approach.
Yeah, so history and clinical examination is, as Margaret said, presentation is viral looking, organomegaly, so keep daily in mind. Malaria is one tendency that we have. Uh, it is unlikely to behave this way, but then yes, entry is one of the important definitions that one would enter with, especially in the absence of rash. And the parents are not so particular about keeping temperature record and at times you take the history with a pinch of salt, but definitely entry to your child, the parents would definitely tell you that the fever there's been no day without a fever infection. So entry would be little low on the list. But the big dilemma is we talk about inculcating culture of certain cultures. And then this is a child where I at least personally have a lot of dilemma whether I should be asking for a culture. If you look at the recommendation, they say you overdo than not do cultures. And then once you poke a child, if picking this child again and asking for a culture again becomes an uphill task. So one would send CBC, peripheral smear, maybe malaria antigen test. The next one would be the sensitivity that it has, almost 100% specific test. One will ask for that and blood culture. I mean, how many of you send blood culture in such a child? So majority would send blood culture. Yeah. So that is the
Picture, the influenza are kind of in 84 to 120 NSOTs and TTs. Those also gives
so the typical hepatotropic virus, like hepatitis A, would have very high HBPT, rising more than HUV. Of course, we have seen HUV also equally high in primary hepatitis. But these tropical illnesses, you don't see transaminitis, which is in the range of say a few up to 200, sometimes 500, unless there is a say dengue hepatitis or malaria hepatitis, where you can have very high HBPT and HUV also. It has a certain clue. Eosinopenia that Margie mentioned will not be, if it is present, yes, it's a good thing. Monocytes is something which is not uncommon in viral illnesses. That is how one would interpret. So, biathenic fever, dengue is something that you must be with now because dengue is such a simple diagnosis. If you treat the patient, make a diagnosis in time. So, as I said before, that saddleback, being used staff, knowledge happening for staff and then wiki case may not be seen in practice. Most of the primary dengue, especially in young children, they are never diagnosed with the past. So they go unnoticed. And the presentation, the first patient can be the secondary contact for that given particular child. So you must call it secondary dengue unless to that. Your serology does not differentiate primary from secondary. Only thing is the sensitivity of NS1 is slightly lower in secondary dengue. Well, NS1 is antigenemia. In secondary infection, antigen is clearly more rapidly, so the sensitivity is slightly less. Again, the timing of test is extremely important. First 3 4 days, very sensitive. As the dose advances, antigens are clear, and there is a window, and that is the window where the child tends to go through critical phase where your antigenemia is not there, not detectable, and antibodies are yet to rise to a level which can be detected by the available test. So that window period one needs to be extremely careful. And time and again we have been saying that it is the clinical presentation, serial CBCs and repeated clinical examination that will help you make a diagnosis.
Even in such scenarios, only chorionic hemoglobin and hematocrit. Then in other cases, if there is decreased intake and hemoconcentration is there.
Well,
But in daily suspected patients, the
it is proportionate.
yes, it is definitely disproportionate. The total count starts dropping to less than around 2,500. And we see a series of patients and again our failure.
Again, one practice point is the hematocrit that we look at is your counter calculated hematocrit. This 3 times the hemoglobin. Ideally, one should centrifuge the blood and look at the hematocrit, which is a practice which is not followed in anywhere almost now. And so, regardless of whether it is because of dehydration or otherwise, if you have dehydration, the hemoglobin is high, counter will give you a high hematocrit. But as Manvi said, it is proportionally high. Secondly, most of the Indian children are anemic. So child was had say 9 months to begin with, for him 12 is also hemoconsumption. So that one factor one needs to keep in mind. And explain danger signs, this is extremely important. Less urine, dark urine, persistent abdominal pain, persistent vomiting, giddiness, somnolence, cold extremities. These are the things that one must explain to the parents and watch for these signs. These are so-called danger signs. And
So, the third question was whether we need to admit this child or not. Also, here again, per se danger signs are not there, so still we can have a watchful this thing over the next 48 hours and we can explain the danger signs.
absolutely. So spare some beds for Manu to admit patients who are really critical. Okay, 7-year-old boy, fever since 8th July. No fever for almost 16 to 18 hours. Cough going on for a week. 8th, the child uses cefalozine and nebulizer. 9th, fever persists of chloroquine is given. 12th, the child goes to the pediatrician and amoxicillin is prescribed. This is a true case.
Yes.
5th case on Monday. And received cetirizine for mood motion from this child in the past. A week prior to this, I received cetirizine. So cetirizine, cefalozine, amoxicillin, chloroquine. And the child has mild. Now, I have a specific question. Satish, how would you have managed this child if he had come to you on, say, 12th of, after having taken cefalozine chloroquine? And what will you do to this child? Now, I tell you examination time. This child, when came, had mild fever, had wheeze. No other problems.
So this case, maybe he had last time some illness in the past, but this time this looks like more of a mild and child is having received the multiple medication. The first thing I would like to stop all the time is sweat loss. See for the fever pattern. Investigate if the child is getting worse or the fever is persistent. And then only take about the decision about the further starting medications or not. In this case, if the child is persistently having fever with high neutropenia or there is a worsening condition, we have to definitely go for the test X-ray and also maybe admitting the child and evaluating compared with the blood culture and the CBC therapy. But giving one more medication or one more antibiotic, I think either because the we have to review our diagnosis or maybe we need to explain the plan about the situation is like if the time is more than 5 to 6 days of development, definitely the current admission for the duration.
I'm not exaggerating. This is a, and I won't name, but this is a prescription by which they get.
Sir, you don't have a chance to stop chloroquine because you finished this.
So I tell you what I did. I did nothing. Just a bronchodilation, this child was fine. The fever disappeared. And that's why some patients, the doctor with the heart level with the So this is
Sir, you're lucky. They are your full for that.
you get the credit for doing You get the credit for doing nothing.
बोलते हैं ना ये कौन I don't.
You get the credit for doing nothing.
Okay. Couple of things, as a remark on the previous case, probably it was 7-year-old child who had food on second, loose motion, so probably that was also a fever with viral illness. That Civic that when he landed upon A, he was absolutely a fine child without any problems of weakness, anything. So that is the second pointer. There is no empirical role of chloroquine at all, and there probably physical examination is no university at all.
So back to back and recurrent violences are again not uncommon in pediatric people. So be confident and tell, because now this patient sir मागच्या वेळेस पण तुम्ही virus सांगितलं वाटच viral then and visas तो patient last time इस monsoon में ऐसा रहेगा and summer में ऐसा रहेगा October heat में ऐसा रहेगा patient के unfortunate price that we are paying for urbanization staying this polluted
I remember sir always saying वातावरण में जैसे वातावरण कितना वातावरण है
वातावरण is round the year खराब है. Okay, so that Monday case was very interesting.
This time I had continued to have fever till 12, right?
Yeah, and after it did well. So it's very difficult to tell parents that, oh, otherwise also the child would have improved. So, but he said, oh, Saranya malaria and so Tuesday, 5-year-old girl, fever for 2 days, including bed, had fever for a day, fever in between, cough, a known wheezer, and snoring also is there. This child had hearing. I did otoscopy, there was congested drum on one side and palpitation from the right side. Left eardrum was congested from the right side. So, would you tell such a, I mean, I thought of improvement in this child. And two things. We test for influenza. This child, of course, was hospitalized. We test for influenza. We use every anti-influenza medicine. What about antibiotics?
As per the guidelines, though it is influenza, but it is on a sick child stage, so I would prefer to start.
Sick, wheezing, tachypneic child.
Point of category ABC whether it doesn't fit as per the guidelines of UV.
So critically, but she was wheezing and high fever and.
So probably I will go for the test, but I will still prefer to start the hospital away.
Yeah.
So that is the take on that.
Right.
CBC again will tell us it is what kind of lymphocytic picture monocytic, so that way we are sure we are not dealing with bacterial definitely. So we will wait on antibiotic, and as we already know acute otitis media could be my N tetralis and N number of we have been discussing. So probably I will still wait because the child is right in front of my eyes. So 8 hours late starting of antibiotic will not make much of a difference. Cracks on the left side, we are known to have viral kind of pictures with reticular nodular involvement of X-rays and clinically going on to finding cracks here and there with the child who is a wheezer. When we are not sure that it is not lobar pneumonia, I will still wait to start the antibiotic.
So
congested eardrum in 5-year-old child with fever, history of fever for 2 days. So AOL guidelines less than 2 years we need to be very aggressive, but above that we can still wait.
So I thought of putting up this case for 2 reasons. One thing is when do you start temporary anti-flu drip? So epidemiology goes through. You have I told you those 3 categories still hold also. Third is a child who is hospitalized. You try and send a PCR, but again, it's not 100% sensitive. Child who respiratory symptom who has a little bit of flushing, viral kind of a picture, and in this particular season with background tumor cases, our threshold for starting empiric anti-flu is little low. Otherwise, not every child would go on anti-flu. Otitis media, one of the commonest viral infections that can cause otitis media is we had 3-4 patients in last 1 week who had unilateral otitis media. And as you put it very correctly, unilateral otitis media don't start antibiotic upfront. Even in a child who's below 2 years, it is laterality that will take into consideration. Unilateral otitis media might be without antibiotic and review the child after. Said here you have a child who is 5 years. And influenza is one infection where when you have lower respiratory infection with influenza, the risk of secondary bacterial infection, strep or staph, is very high. So if you have a sick child who is influenza positive and has low respiratory infection, again our threshold for starting antibiotic is very low. We do start antibiotic.
So,
Yeah.
coming to the starting of Oseltamivir, most of the cases are coming after 2 3 days of illness, and then
So there is, I mean, a lot of talk about rationality of using antivirals in the first 24 to 40 days. But in children, we are seeing even at the time of diagnosis, you treat this child and they feel breakdown. So, gone are the, the whole recommendation, right? If it is beyond 40 hours, you don't start. Beyond 40 hours, the child has had a benign course and has not required in hospitalization or is improving, you may not start. But in a sick child, yes, you will make a diagnosis on day 6, so one will start anti. And there is no role of prophylactic anti to the close contact, family contact. If you suspect, go ahead and treat it. Okay, 3-year-old by age febrile, you are a similar case. So, I mean, I put it because just to tell you that influenza is a very common viral infection which is responsible for otitis. Yeah. Temporal over cough, cold, feeding, but with difficulty. Father had little URL illness 3 to 4 days back. Child is technique has subcostal traction, but active child has wrong time. Chitu, what is the most probable diagnosis?
so acute respiratory infections, when the child is coming, we have to see the age groups. If this is age group between 6 months to 2 years, we have to think of bronchiolitis as the first thing we saw. So clinical diagnosis is bronchiolitis with tachypnea and some fever to start with, and cough, cold and bronchi. So we will give only hydration, nutrition of the child, oxygen if required, and there is no actually role of nebulization also. So time, we have to give time, nutrition and oxygenation.
Yeah, so we have started seeing a lot of cases of bronchiolitis in last 15 days also. And like influenza, we have more of bronchiolitis in wet months. You have a smaller peak occurring in western region of India, which happens around January, February. And mild cases can be treated on OPD basis, moderate to severe cases may require hospitalization. And we have a monoclonal antibody now that can be offered to children born during season or children who are born before the season and who are entering the season. Give one dose of receiving an app and that can be. We have shades of bronchiolitis at our hospital. We are infant in bronchiolitis, tachypneic distress admitted. We had a preterm baby who was discharged, came back with bronchiolitis. We had a RSV pneumonia. Yesterday, another pneumonia was admitted by Dr. Kapil in the Apollo. So RSV can be mild bronchiolitis to bronchiolitis requiring admission. To have, on the other hand, you have low respiratory infection. Now, my question, anyone can think, like influenza, do you start antibiotic in all RSV cases? I give two scenarios. One is RSV and bronchiolitis, which is being treated on October basis. The clinical diagnosis RSV was not done. Second scenario is RSV bronchiolitis hospitalized. And third is RSV pneumonia. So, what is the role of antibiotic when you start it?
So the hospital child is right in front of our eyes. So I will stay in the first go, not put an antibiotic. We wait for the reports. We will get an idea about the what we are dealing with from the
So, I tell you, report is hemoglobin is 10 and counts are 12,000.
Yeah.
And 50% improved, platelet 2.2 lakhs. And child has tachypnea and is infant and is bronchial. My diagnosis bronchial, RSV PCR score.
RHO PCR probably the child wouldn't have done in my signal from outside. So when such a child comes with me, my diagnosis is bronchiolitis plus depending on what the state of nutrition is and how overcrowded and what kind of clustering in the population it is, then I will put this child on broad spectrum antibiotic.
So by and large, bronchiolitis children don't get secondary infected so easily, but RSV pneumonia, once you label a child as pneumonia,
Yes.
our threshold for antibiotic is low and we do start. We had a patient of RSV pneumonia last year. Now, with seasonal illness, monsoon and Jan, secondly, no antibiotic or steroid or bronchodilator. Bronchodilator, of course, you decide the need based on the response to the first use of bronchodilator. If the child responds, you continue. Again, that assessment of response is not so easy. And supported treatment is what is required. But again, unfortunately, every child of bronchiolitis is not. let's accept it, that most of us will start antibiotic. Let's get out of this.
So you all are getting RSV positive.
Hospital especially we do test. We have by now over a dozen of RSV also.
But whatever we have been doing even in this, so they are getting all the viral parallels negative. Still the trial is still can create.
We have influenza, we have other viruses, respiratory viruses, and we have RSV.
But those all.
Arjan has a patient who was preterm went home. Shrikant had a couple of patients with bronchitis. Chitra sent a patient of RSV pneumonia last week. Yesterday, Kapil admitted a patient with RSV pneumonia.
But do you have certain patients who are negative for all certain families and still?
There are many patients. There are many patients who are. Yes.
So, as Martin is saying, you are in a whole of Martin in physical hospital and in between. So, where to send the respiratory panel?
Hospital especially, you must make an attempt to establish a diagnosis. So that one thing is, you are getting more confident of starting or not starting antibiotic. It becomes easy to counsel the parents also. Otherwise, we'll go on adding and subtracting more.
And our hospital, we have generated a code at a very serious loss, so we are sending for all the patients now.
So this 8-year-old fever for is high grade with chills, fever just palpable, spleen not palpable, fever without focus. So of this test, do you ask everything in one go or you follow stepwise? This is day 3 of it.
So usually this is very common scenario. First of all, we see how the fever is, the pattern of fever. If it is still persistent or on increasing sign, I usually examine see for any danger signs or any significant outside clinical cues. If it is so, then definitely we go for at least CBC and MPP, like US and then one is antigen, sorry, CRP first. Then we know about the basically we do not have a cause, then we have to make a differentiate our clinical cure.
So this initial battery of test give you important clue. But not to forget, we have virus malaria with high CRP. And that does not warrant treatment with antibiotic, of course. And then usually it will come with high CRP. Rest of the virals will not have high CRP. Influenza is one viral infection where CRP can be high. I think for want of time, I'll stop here. I'll go to the last slide. So these are the common illnesses that we come across in monsoon: dengue, malaria, influenza, acute fever, other viral infections, and acute gastroenteritis, hepatitis, both URI as well as LRM, RSV, and influenza, VSC, cases. There are other illnesses. And epidemiological clues are extremely important. That will guide you, prioritize your testing and management. Follow the age hit approach, history, incident treatment, and right test at the right time in the right patient, and practice both diagnostic as well as antibiotic solution. Thank you so much, my panelists, was wonderful.
Thank you, sir, and thank you all the panelists for the wonderful discussion. I think we all have better vision tomorrow when we start. I call Dr. Subhash Rao, sir, for facilitating panelists. Thanks, sir.
Thank you.
Yeah, the Madhya. Okay.
Good place for you.
इकडे
Madhya into solution.
एक मिनट सर
This hand.
नाम नहीं दिखा नाम डरता है
I don't get this presenting helps.
Next speaker.
Including 10 minutes before.
Okay.
Suddenly service stopped. You know?
हाँ
He doesn't know. You have to go.
कर दीजा व्हाट्सएप I'll have to make meeting notes.
Okay.
Big case completed.
Yeah.
Yeah.
Yeah. Just was. I didn't join it.
Please get protected.
Yes, yes, the first question.
So, I request Dr. Danya to moderate the next session. So, it is going to be conducted online. I request all the delegates to may note down their questions on the papers, which can be taken at the end of the session.
Hello, Dr. Lakkumar, sir, have you joined? So while he is joining, what we request is Dr. Asmita will share paper because the problem is that the questions can be asked only from here. So if you can share your question, I can ask you the questions. He'll be able to see you.
Take a chair or take
We can also keep a chair in case you want to come ahead and ask him question. How do you know when you join it? By using the first time. Actually, we thought the session will take another 5 minutes, so we messaged him accordingly. So that's why it delayed. Dr. Mangai, yes, message to email the link again. Copy or link and share. Hello.
Hello. Can you hear
Sir,
me?
can you hear? Yeah.
Yeah, I can.
Can you hear the audience?
Yeah, I can.
Okay. Thank you. So, thank you very much. It's a great honor for us in Navi Mumbai that you agreed to give us a talk on dengue. Let me introduce you. He's a very well-known international faculty. So when we think about dengue, his name comes in the mind. He's a senior consultant pediatrician and he's a founder clinical head for Center of Clinical Management of Dengue and Dengue Hemorrhagic Fever in Negombo in Sri Lanka. And that center is the world's first dengue treatment facility. And they treat patients of all ages, from newborn to, all ages, till 100 years probably, under one roof. And he's a recipient of several awards, Outstanding Asian Pediatrician by Asia Pacific Pediatrician Association in 2016, as well as he has received National Award from Pakistan for his contribution to Pakistan's dengue epidemic. And he has been an author for national as well as WHO guidelines on dengue. So we are very privileged, we are very honored that you have agreed for this talk. I just stopped sharing. If you can share your slides, sir.
Okay, can you see my slides?
Yes, can you please make it full screen?
Yeah, just give me a second. Okay. Right.
Thank you.
Just give me a second. Okay, so what I'm going to do is to tell you about the case management learning curve of dengue. Uh, just give me a second for me to set my clock so that I don't exceed time. Just give me a minute. Okay, so I'm really going to talk to you about my first-hand experience of managing dengue as an involved party over a long period of time of about say 15 years or so, so that where I manage the dengue patient every day. They're not moving. Yes, my slides are not moving.
Sir, please click on the screen first and then it will start moving.
Okay, right.
Yeah.
So, but the question is whether dengue can be made a zero mortality disease. Zero mortality disease. I believe can be made a zero mortality disease. And during this talk, there is a question time. Please do not silently tolerate your disagreements. I'll be telling certain things that are new to you and you may not have heard before. So please ask me questions, and healthy confrontations are always useful. I come from this place called this, what was described in the introduction. I mean, we have managed patients from neonates to the 100-year-old. And what I'm going to talk is based on a big database of more than 17,000 patients over a 15-year period. You know, the dengue viral infection is a disease that is where the severity changes, and mostly if you get dengue for the first time, you will develop mild disease. And there are 4 serotypes, and you get lifelong immunity against each serotype when you get dengue. And but you can have cross protection also that lasts for about 3 to 12 months after each infection against all 4 serotypes. But you can, after that, you can get dengue again. But out of all your dengue infections, the second time dengue is the most severe. The third and the fourth time are a little better than the second time. Uh, And now, when it comes to dengue fever and dengue hemorrhagic fever, I think dengue illness has two different clinical entities. One is dengue fever, the other one is dengue hemorrhagic fever. Most people who get dengue for the first time develop dengue fever, whereas those who develop second time, still most of the people who get dengue second time still get dengue fever without leaking. But most of the DHF patients or the leaking patients are people who have got dengue more than twice or more. Right? So, what I'm going to tell you is how not to make natural dengue difficult dengue needing ICU by managing better in the ward setting. My experience is also mostly in the bedside case management, and which I've made through learning, right? So the case fatality rate, I told that in our setup, where we have had in my center where patients who admitted more than 100,000, we have had zero mortality for several years from the time that it was started. I'm going to talk about new concepts on bedside clinical management, which I believe can change the fear we have about dengue and its outcome. I want to really tell you about achieving zero mortality through 7 important steps. Out of the 7 steps, what is highlighted in yellow are things which I have introduced to the dengue world. Out of the 7 things are to do a rapid dengue antigen test for early diagnosis, use routine bedside limited ultrasound, and keep the pulse pressure above 30 all the time in your clinical management, and calculate fluid quota for leaking phase as soon as leaking is identified. Give fluids at a flat rate of 1.5 ml with intermittent boluses. Then the gradual increase and decrease, which most of you are familiar to do. Then do capillary hematocrit to guide fluid therapy, and use volume over time scale or watts to decide intervention. So some of these terms may be new, but maybe during the talk you may be able to understand. Now, there are 2 classifications of dengue from 1975, that is dengue fever and dengue hemorrhagic fever. This is the initial classification, which was later improved in 2011, and accordingly you get dengue as a viral illness. Some will are symptomatic, majority are asymptomatic. You have patients who have some unusual or expanded dengue where you cannot put them into either DF or DHF category, but these are a very very small group of patients. Then out of the patients who develop leaking are called the plus patients who develop leaking. Then if you have leaking, the leaking can produce hemodynamic instability. If you have shock, then that is called dengue shock syndrome. Patients who develop leaking without shock are considered DHF grade 1 and 2. Shock is DHF grade 3 and 4. The other classification is 2009 classification by WHO TDR group, and it's talked about dengue, probable dengue, dengue with warning signs, and severe dengue. But one of the biggest problems with this classification is that it seems that the dengue is one disease entity with different clinical presentations, often with unpredictable clinical evaluation and outcome. Whereas the DF-DHF classification tell that these are 2 distinct entities. This says it is one distinct entity. Uh, Now, whatever the classifications are, over 95% of dengue deaths occur in the patients who develop leaking. So that's the most important thing. Managing leaking patients better is the best way to reduce deaths. Severe dengue of the 2009 classification is mostly DHF of the 1997 classification. That's what I want to say. If you really look at the natural cause of dengue, you have the febrile phase, the critical phase, and the convalescent phase. I'm going through a little faster, thinking that most of you may be familiar with some degree of dengue, and if you don't have the critical phase or the leaking phase, then that is called DF or dengue fever. So that's the difference. If you follow the white cell count and the platelet counts of these patients from beginning to end, you will see that during the leaking phase, initially you will see the white cell count and the platelet count both are dropping due to the bone marrow suppression that you have due to the virus, the effect of the virus on the bone marrow. And later, when the viremia is going away, sometimes the fever comes down. The white cell count start rising, but the platelet will start dropping in patients who develop leaking. The patients who don't have developed leaking, the platelet count will also start probably going up, and the platelet count will start dropping, and then at a certain stage, the platelet count will start rising. So when the platelet count start rising, and 99.9% of the time when the platelet count start rising, the leaking is over. So that is something that you need to keep in mind when you're following patients with the serial platelet counts. Whenever you see the platelet count rising, then the leaking is over. So one of the other things that I want to draw your attention to is that during dengue epidemics, most patients die in hospital. And unlike in the other diseases like cholera or other things, where a lot of patients die at home too, we hardly see patients dying at home in dengue, and most of them come to hospital. So we really need to think whether they die in hospital, whether they die as a result of coming into hospital. It is possible because We are pressing the panic button unnecessarily. If you take, for instance, this is a 25-year-old patient whose systolic blood pressure is 86 and diastolic is 42. Will somebody give a inotrope to this patient whose heart rate is 70, the patient is otherwise okay? So just does not need any intervention. Same thing here. And this lady's heart rate is 36, but her pulse pressure is good. This does not need a pacemaker or any other intervention. So that's one of the reasons why that sometimes when the patient come to hospital, our overreaction can make things worse for this otherwise self-limiting disease. So the aims of better management for dengue is to sort of understand this disease well, and then be proactive than reactive. So the one of the most important thing that you made to make, I told, is to make a diagnosis of dengue early. I won't go into details why this is the best, but I'm telling you that in 19 now we have the NS1 antigen test, and what you need to do is to use a good kit, and whenever somebody comes with fever, at the end of 24 hours, do the dengue NS1 antigen test. You will exclude if you use a good test kit, you have more than 95% chance of detecting dengue. And there is no other disease, no other infectious disease where you can make such an early diagnosis. So use this test, and use a good test kit and use this test. Waiting for to do a full blood count on day 3 is not good enough if you want to aim zero mortality. I mean, occasionally leaking can start as early as day 2, and patients can die of dengue by about even day 3. And if they start, these are three such examples where the first two patients died by day 3, and the third patient platelet count was down to 11,000 by day 3. So don't wait till and started leaking. Don't wait till day 3 to do the full blood count. Then there are some doctors who purposely avoid diagnosing dengue to justify the use of NSAIDs and steroids because they come with very high fever. Controlling fever becomes a problem, and if you diagnose dengue, then you can't give NSAIDs. Therefore, people delay doing the NS1. After diagnosis, the next most important thing is to do the full blood count. So when to do the full blood count, when to do the first one, and when to repeat. Either you have to do daily full blood counts until the platelet count show convincing repeat rise. If you are diagnosed, if your NS1 has become positive, then you need to do once a day, at least once daily, full blood counts. When you do the first one at the end of first 24 hours, repeat that one the next day. You can see the rate of drop and how it behaves to decide how often you have to repeat it the next. Then the other next is to differentiate DF from DHF as early as possible. Now, one of the things that you really need to do is that you identify the patients who are leaking, and then what the leaking period is. To identify onset of leaking, the best way to identify, I'm going to talk about it soon, is to do a bedside ultrasound. The best way to identify end of leak, that is beginning of leaking, is by doing a serial ultrasound where you will see fluid accumulation. The best way to see where the leaking ends is by identify a definite rise in the platelet count. So these two, beginning and end of leaking, can be decided through these two parameters. Now, if your fluid therapy for patients with dengue is different in those who leak and do not leak. For patients who do not leak, the initial fluid therapy or before starting leaking, when the platelet count is above 150,000, it's like any other viral illness. Just give free oral. If they cannot tolerate oral, give IV. Manage the vomiting, correct dehydration. Drink what is sufficient to have your usual urine output. Not too much, not too less. Then just maintain a good intake. Now, natural dengue is generally a 7-day illness where some start leaking. Usually, they start leaking at day 3, commonly day 5, but rarely even day 2, may cause early death, or very rarely even at day 7. Usually, when platelet is less than 100,000, rarely when platelet count is above 100,000. So DHF is a leaking syndrome, that is transient plasma leakage through capillary walls. Only in this leaking happens only in the pleural and the peritoneal cavities for a period of not more than 48 hours. The volume loss in the intravascular compartment can lead to shock and organ hyperfunction. This is the reason for deaths in dengue. So the fluid, the most important and fascinating thing is that the natural fluid leaking of dengue follow a pattern. It starts around the gallbladder, then go to the Morrison's pouch, the potential space between liver and the kidney, and then to the pelvis, then peritoneum, then to the right pleural effusion and the left pleural effusion. And when this follow a pattern, and when leaking is over, when the fluid start reabsorption, the reabsorption also happens in the same pattern, starting from the Morrison's pouch, then to the pelvis, then to the peritoneum, and right pleural effusion. So the left pleural effusion is the last to disappear. And when it is absorbed in the Morrison's pouch, the gallbladder wall is the first to disappear. And if you have a patient who's got body swelling, periorbital puffiness, pericardial effusion, these are not due to natural leakage, they are all due to giving fluid in excess. So, in summary, that these are two different entities. Large majority of dengue deaths are inside DHF. Managing DHF better is the best way to reduce dengue mortality. DHF is not badly managed DF, but dengue grade 3 and 4, or what you call dengue shock syndrome, is often badly managed DHF on N2. This is an example of, one of my students' father. He was his platelet count was down to 2000, and he was behaving very badly without resting or anything during his illness. And when they tried to give him a platelet transfusion unnecessarily because the platelet count was 2000, he got a reaction and had a cardiorespiratory arrest, and he had to be ventilated for a day. And went to meet him to see him the next day, and he was just extubated, but he's smiling and waiting well now because he's a DF, because he did not have leaking. Now imagine if this patient was a DHF, he would have died during this episode. So that's the difference between DF and DHF. When leaking is detected or suspected, fluid therapy needs to be changed. Leaking is DHF. If you give more fluid, there will be more leaking and fluid overload. If you give less fluid, there will be less leaking. But you can give less fluid and control your leaking. You can make your effusion smaller by giving less fluid. But if you give too little, then the patient will go into shock. Still, there are no good predictors to suggest who will leak before it happens. But once leaking is identified, and you know that this patient is a leaking patient, dengue is a predictably treatable disease. So what the 2009 guidelines said, that it is often unpredictable, is not true. And so DHF is largely predictably treatable disease. So differentiating DF from DHF early is the most important. Can the warning signs of the 2009 guideline do it? No, it is not perfect enough. If you really look at it, one of the warning signs is clinical fluid accumulation. By this time, when clinically detectable fluid is accumulated, then it is far too gone. It's not a good warning sign at all. By this time, dengue has progressed too long. Right. So the best way to objectively identify leaking is through bedside ultrasound of chest and abdomen, just selectively chest and abdomen. You don't have to scan the whole patient. And routine ultrasound is standard in Sri Lanka. Now I'm sure India is a much more economically high level country compared to Sri Lanka. So this is easily possible in your setup. Now, when routine bedside ultrasound is possible, uh, you don't need warning signs to detect severe dengue, because we are in 2025. Why should we just depend on various indirect methods? Best is to objectively see whether the fluid is leaking through an ultrasound. So seeing is believing. It is an objective way to know whether the patient is leaking or not. We started this in 2012, and we've been using this in a very large scale during major epidemics. We have published about its use. Now, is it doable? Yes, it's only limited ultrasound, leaking scan. Leaking follows a pattern, as I told earlier. And the objective can always recheck. If somebody says this patient is leaking, you can always go and rescan and see whether the person is saying the correct thing or not. The training is not exhaustive. You can just train a person to do the limited ultrasound in half a day. Leaking scans can take only few minutes. It's faster than any even blood test. No reagents are needed. You can keep, you only need the jelly. You can keep repeating the test with no cost. With no cost, right? And so DHF is a leaking syndrome where you have fluid leaking into these limited spaces. When the platelet count, when to do the ultrasound, when the platelet count is dropping below 100,000, when you're managing when you're monitoring the platelet count, when it is dropping below 100,000, that's the time that you should start, or when there is a very rapid drop, is the time that you should start doing your scans, and then you will need to keep repeating it to detect leaking. This is the ultrasound scanning form that we use, and you only have to just see the gallbladder, pericholecystic feeding, pelvic fluid, right pleura, and put a tick and see the amount of fluid. So it's not you can miss a tumor or anything, and you will not be blamed for doing that in the bedside ultrasound. Now, if ultrasound is negative, what does it mean? It means either the patient is a DF who is not leaking, or a DHF who has not started leaking yet. What about the capillary PCV? Capillary PCV is essential for perfect fluid therapy. So time to time you have to do capillary PCV, but remember that when ultrasound is not available, it can be used to detect DHF, but it's not the best to identify leaking. You cannot achieve zero mortality only by using PCV. Now, the aim of fluid therapy should be to avoid shock and reshock while not causing overload. And by monitoring the most important parameter, the pulse pressure, heart rate, PCV, and the urine output. Once DHF is identified by objectively seeing leaking and showing repeated scans that the leaking is progressing, then all what you need to do is to make sure that your pulse pressure is above 30 all the time. This pulse pressure value of the systolic diastolic difference of 30 is constant for all patients of whatever age. Whatever age, if you and from neonate to the elderly, you will have a pulse pressure of more than 30, and you need to make a pulse pressure of more than 30 all the time. And when pulse pressure is between 30 and 25, you need to plan an intervention. By any chance, if it is less than 25 and remains so for more than 20 minutes, you need to intervene. The patient will look all right, even with the pulse pressure of 24, 25. But don't wait. This is an emergency that you really need to intervene in the pulse pressure is less than 25. And the most important thing is about tachycardia. Whenever a patient's heart rate is more, please do something about it, and think that this is an important. I've been to many dengue death reviews, and I've seen that most of the patients who have died, they have had tachycardia going on for sometimes day, half a day, and many hours before the patient became bad. So tachycardia is a very important thing. Tachycardia is possibly the most important warning sign useful for best outcome in dengue, but it's not a warning sign in the 2009 classification. And so if you have a patient with a tachycardia, do things like control the fever. Is the tachycardia disproportionate to the fever? What was it now? Sometimes people will just put it to tachycardia, say this patient is having fever. But look at the fever, the pulse chart and the fever chart, and see. Yesterday, when the fever was 100, his 101, his heart rate was only 95. Today, his heart rate is say 120, but the fever is only 99.5. So don't put everything into fever. Check on the fluids, urine output. Ask whether the patient is thirsty. If so, and do a capillary PCV whenever you see. Give the first dose of calcium when you see a tachycardia. Check for bleeding. Send a stool sample for occult blood. When you see tachycardia which is not resolving, consider giving them tranexamic acid. Give face mask oxygen to any patient who is having tachycardia, which cannot be accounted for by excitement or fever. Right. If you are aiming for zero mortality, you need to do judicious fluid regime to maintain the key parameters. And the main idea of the fluid regime is to avoid prolonged shock, overload, and massive bleeding. So these are the three main causes of death in dengue. And if you see most of the fluid regimes, the people use fluid regimes where you have an ascending and descending fluid rates. But the basis of most of these regimes are that in dengue you have an ascending limb of increasing leaking, and then there's a descending limb where it gradually goes down, and then there's an equilibrium phase, nothing happens, and then the fluid start reabsorption. And people think the way is to just mesh the leaking. So what I suggest to you is to calculate the maximum fluid uh, volume by using this formula of fluid quota of M+5, maintenance plus 5%. You can actually get my presentation from the organizers, so you don't have to sort of remember this. This was inherited from Thailand, and then we use this, and this is the most useful way to manage the fluid quota, the total fluid that is needed to give a patient during the leaking phase. The duration of leaking almost never exceed 48 hours and can be as short as 6 to 12 hours. It's mostly 24 to 48 hours. If the duration is less, the fluid quota is proportionately less. So if you leak for only 24 hours, maybe that the amount of fluid that you will need is only half of this total fluid quota. People think that you have to mesh the leaking, but remember, leaking volume, rate, size, and effusions are not completely independent to the rates of fluid administration. If you give more fluid, you will have bigger effusions and leak more. And if you give too little, you will get into shock and hyperperfusion. And I told earlier about the timing. So when the platelets start rising, wherever you are, whatever your initial assumptions are, you need to think that the patient's leaking is over. I advocate to give only a total of 1.5 ml per kg per hour of fluid. Give 0.5 ml IV and 1 ml oral per kg of fluid. You can just when you're calculating the weight, you have to either use the ideal body weight, actual body weight, or adjusted body weight. Um, the total fluid is 1.5 ml. When I give 0.5 ml as IV and 1 ml as oral uh, during the day, uh, and so what we are trying to do is to give the minimum amount of fluid needed to maintain an hemodynamic stability, that is while maintaining a urine output of more than 0.7 to 1 ml per kg throughout. So that's the idea of giving fluid. And when these things, when the pulse pressure is low and the urine output is low, or when there's tachycardia, we really come to do interventions. So for children, we give 0.5 ml IV and 1 ml oral per kg. If you take for an adult or a bigger child, you give 25 ml IV and 50 ml oral. And for infants less than 10 kilos or less than, say, 2 years or so, you can use 1 ml IV, 1 ml oral. So you have to monitor the parameters to decide an intervention. In the night, when the patient is sleeping from 10 p.m. to 6 a.m., we give a total IV of 1.2 ml. But in between, if the patient is thirsty, the patient is asked to take double the oral volume that he is taking. What are the fluids that you can use? You can use either normal saline, Hartmann. Uh, can use colloids also, like Dixtran, blood and blood products. I don't think this talk is enough to tell exactly when to use them. So the intermittent boluses, hemodynamic instability, low urine output, the indications for the intermittent boluses, but another indication is high hematocrit. But one thing I need to tell you is the high hematocrit is depending on the clinical situation. You really need to be ready to tolerate a high hematocrit. If the patient's pulse pressure is more than 30, the heart rate, there's no tachycardia, the urine output is good, don't just give fluid to bring down hematocrit, because it'll settle with time. So with time, right? And So intermittent boluses, while on a flat rate, right? So do capillary hematography before and after. Now, whenever you give a fluid bolus, you need to do a capillary hematography before and after each bolus. So when we are giving fluid, we can give it as a full bolus or a half bolus. What I say full bolus is to give 10 ml per kg given over 1 hour, and half bolus is giving 5 ml given over 30 minutes. When blood is indicated, commonly for suspected bleeding, we give blood at a rate of the same rate of 1.5 ml per kg per hour over 3 hours. Forward massive bleeding, you need to give faster blood transfusions depending on the rate. So when you're giving fluids, remember when you are giving fluid, that everybody will leak. Think that everybody is leaking only for 24 hours, and try to manage. You have got a fluid quota. You try to manage the leaking with half the amount, and see at the end whether you have whether the patient has hemodynamics changes suggesting that the leaking is continuing. So this is what we published about this flat rate fluid, where we showed that out of in my unit, all the DHA patients whom we have managed, we have got this fluid charts to prove that this 1.5 ml fluid works. So another thing that I really want to mention is, I know that I may be going over time, is to do, I want to introduce a term called WATS, or volume over time scale, to decide your intervention. So while giving the minimum fluid needed to maintain parameters, any fluid left from the quota can be useful. So the volume over time scale is see how much fluid is left in your fluid quota to manage this patient. And this is a formula. I don't mind if you want, you can make a screenshot of this formula. And whenever a patient is having either low pulse pressure, low urine output, or tachycardia, or any other instability, you really need to quickly calculate the Watts and see. Normally, most dengue patients can be managed with the Watts of say 70 to 80%, and so it'll help to decide what to give. And suppose you have patients who's we can use furosemide also in dengue in whatever stage, not even at the ascending limb or the descending limb or the initial or the later. All what you need to do is the amount of fluid, the furosemide that you can use in dengue is a very tiny dose of 0.05 to 0.1 per kg, and during leaking, you can also give oral furosemide during the recovery phase. One of the things to go by is that if you have a patient whose urine output is low, just see what your Watts is. If your Watts is above 90%, you better before giving any more fluid, just try to give this 0.05 milligrams of furosemide and see whether that will sort out the urine problem. So in this study that we published, we showed that 65% of the patients could just complete the entire leaking phase by just a flat rate of 1.5 ml fluid, 0.5 ml IV, one oral, without needing even a single intermittent bolus. Another 12% needed an intermittent bolus, just one intermittent bolus. Only 10% needed both crystalloid and colloids. So that's the with this fluid regime we have maintained zero mortality, and so most of the people, when they listen to me that I give less fluid, they can't believe, and then they try to give they reduce their fluid rate which they're giving 4, 5 to 2 to 3, but don't do that. This 1 point, it has to be 1.5 and not 2 to 3 ml. It's not an alternative. If you don't want to come back to 1.5, just keep your whatever the fluid regime that you are used to, because if you give 1.5, there will be less leaking, no fluid overload. And if you give at 2 to 3.5, you will get fluid overload and prolonged shock both. If you give more than 4 ml per kg, then you will produce. So in fluid therapy, each patient can be managed in many ways and with different rates and choices of fluids, but try to master the way to smoothly manage by aiming both shock and fluid overload. On the request of Dr. Yawale, I just thought I will quickly tell you something about HLH. The hemophagocytic lymphohistiocytosis in dengue. One of the things is it's the only indication to treat dengue with steroids, and it's a rare life-threatening immune disorder. And usually they have persistent fever and hepatomegaly. One of the things that you really need to realize is that in the classical HLH may not be seen in is seen in dengue is different to the HLH of the malignancies and other things. Splenomegaly is uncommon. Lymph node enlargement may be uncommon, and of course, headache, sleepiness, headache, irritability are the features that you see in patients. And most of the time, they have high fever. This is one of the HLH patients whom I had to kind of come in the middle of the night to do a bone marrow and give this was the patient was ventilated, and I gave did the bone marrow in the middle of the night from the sternum, because there was no hematologist available to do it at the night, and this soon after the next day, patient had a dramatic recovery with the steroids, and this was the patient. This is another patient with HLH, where we saw these patients. See, the ferritin was 300, more than 300,000. This is very high ferritin, and here you had this patient. I mean, it was a long course, and we had to manage all the other comorbidities and secondary infections and so on. And these are the patient at the end. But remember that there is a thing called hyperferritinemia in dengue. So all the patients with high ferritin, you should not overdiagnose HLH to treat them. This is another example. This patient was a 21-year-old patient who the serum ferritin was 44,000, but the patient was otherwise stable. So we did not, the Leo functions were also high, but we managed the patient's other parameters, repeated the ferritin the next day. Say in 2 days, the ferritin came down to 22,000 without anything. So the patient did not need steroid. We did not give steroids. So that's the other thing that you really need to remember. The key so transient self-limiting hyperferritemia with HLH-like phenomenon may be occurring in various degrees in severe dengue. And the key points that I want to mention about HLH is don't wait for all general HLH criteria to diagnose HLH. Suspect when fever does not settle. More likely persistent infection positivity is noted. Ferritin is one of the most important, but look for a rise. Rapid rise of levels above 50,000 need treatment, but if rising slows or levels come down with clinical improvement, don't rush to give steroids. Spontaneous resolving hypertension is not uncommon in severe dengue. Manage the comorbidities or co-infections optimally. Always do a bone marrow before starting steroids. I think I'll stop here. I think I've just taken the time allocated me. Thank you.
Uh, Thank you so much. And we have been introduced to new concepts, I would say, with the fluid management. Hello, can you hear me? Sir?
Yeah, I can.
Thank you very much. You can stop sharing the slides
Yeah.
or reach. Okay. Coming questions because the concepts are new. Dr. Mohit, so you need to come here.
Good morning, sir. I've heard you. I think this is the fourth time I'm hearing on dengue, and every time I follow your concept. Every time I listen to you, I get some new idea. So first thing which you said, DH and DF and DHF are two different entities for clinical practitioner, which is a wonderful addition. Earlier we recognized DHF, better the survival. Now, I have got few questions in my hand. One, you said the mortality for more than 1 lakh platelet was zero. What was the mortality for less than 1 lakh platelet in your cohort?
No, that is when I say more than 1 lakh means patients who have come to us early. Out of about 60,000 dengue patients whom I've seen, we had less over a period of about say more than 10 years. Out of 60,000 dengue patients, we needed only ICU care for less than 30 patients out of the 60,000, right? There were less than maybe 20 deaths, less than 20 deaths in this whole group, but they were all people who have come in an irreversible state. But I would say that if I had to this, because they come late in the sense that most of them after the leaking period is over actually, because already they have had prolonged shock that has gone on for more than 7-10 hours, where they've had severe liver damage. But we had patients whose liver functions were 25,000, and we were able to get them back. And most of these patients were people who have been given NSAIDs, unfortunately.
Now, the next question is, all of us are pediatrician here. You said your clinical monitoring parameter most reliable and dependable is maintaining the pulse pressure more than 30 millimeters. Now, in an infant less than 1 year, you know how difficult it is to check it manually. So many of us rely on non-invasive BP. Many of us don't put IBP lines, and obviously with that low platelet count, it may not be advised. How do you
Actually,
check the reliability of
uh,
NIBP
actually
in
speaking,
pediatrician?
actually speaking, if you really look at this, blood pressure is a very. That is why I always think that you need to use a good multipara monitor. I mean, the multipara monitors that are used in the PBUs or the it's not the electronic blood pressure apparatus which is available for a couple of thousand rupees. But if you really look at a good multipara monitor, right, which is say maybe more than 100,000 Indian rupees. The good ones are capable of measuring accurate. So you really need to, actually speaking, to for zero mortality, that you really need to, for the patients who are critical, you need to use a good multipara monitor to check.
I agree, but we have all these blood pressure manufacturing companies take it the highest end. On their manual itself, it is mentioned the NIB becomes unreliable once it goes into lower ranges, especially the hypertension ranges. That's the reason. So that's the one limitation. I'll come to the next point. You already mentioned about immunomodulators, and you mentioned about Dextran 40. What's your take on that? I mean, we have not used. Your experience is it's very safe. Your literature mentioned there are some unsafe things coming with that. We are using nowadays balanced salt solutions quite a lot. We are using normal saline for ages. We do find some difficulties. Your Dextran 40, which is a wonderful colloid. So can you just say something about Dextran 40
Yeah.
safety?
Yes. Actually speaking, Professor Suchitra is the one who, she said that she's the one who started using Dextran 40. Long time back, in Germany, for these Jehovah's Witness patients who did not want a blood transfusion, they use Dextran 40, and she used Dextran 40 when HIV became a problem in Thailand, because earlier the college that they were using was FFP. Now, Dextran 40 is a solution with a very high oncotic pressure, and Dextran 40 is a substance. It has its average molecular weight is 40 daltons, and in the plasma, the albumin's molecular weight is 60, but it still leaks. Now, when you use the Dextran 40 solution, the Dextran 40 solution has 20,000, 100,000, 40,000, and different size molecules, but they have a ability to coalesce together to form a practically large molecule. That large molecule will not leak through the leaky capillaries. So that's the idea. But when you're giving Dextran to a patient who's during the leaking phase where capillaries are open, you need to give it as a bolus. If you give it as a slow infusion, then it can leak because the small molecules can leak. But Dextran, compared to normal, if you give a patient with shock, normal cell line, the normal cell line will disappear from circulation in couple of hours. Whereas Dextran can stand inside. So when if it is 1 to 2 hours, normal cell line will remain. Dextran will remain in circulation for maybe 5 to 7 hours. So because this is a time disease, leaking will be over in 48 hours. So by giving Dextran, you can actually hold on to time. But the amount of Dextran that you have to give, there is a limit because it can have renal effects if you give too much. Before giving Dextran, you need to give that all the patients with leaking that you are giving, that you have to give at least 20 ml per kg, 15 to 20 ml per kg of crystalloid before giving Dextran. Now there are studies that have compared crystalloids and Dextran and say that they are both are good. Those are stupid studies because the indications for each is different. You need to always give a crystalloid and then make sure that you have adequate fluid in the system before giving Dextran. So don't give Dextran to a dehydrated patient. Give only after giving this thing. And the amount of Dextran that you can use is only 30 milligrams per kilo. That at one time 10 ml per 10 milligrams per 10 ml per kg per kg, only 30 ml over 24 hours. So just if you are giving boluses, only 3 boluses. Of course, in our clinical practice, you don't need even 3 boluses for the whole 48 hours. The amount of Dextran that you need is very small.
This last question. Few of us are intensivists here, and what we have seen in Indian scenario, as you rightly said, mortality for dengue fever is zero. Even capillary leak syndrome is almost nearing zero. The only thing that bothers is hyperinflammatory cohort of the dengue, and where there is a lot of debate beyond going even steroids. We are talking about IL-1 blockers, anakinra, IL-6 blockers, tocilizumab. So what's your experience and take on those entities? Are you using them? How they are affected? On our cohort, we are finding it definitely life-saving in few of the patients.
Actually speaking, the most important because if you really look at the natural dengue, none of these things will be needed in natural dengue. I mean, I would say that there may be patients. I said that there are no dengue deaths at home. There may be few patients who will leak at home and recover with the physiological mechanism. So most of the time, what we need to really do is undoing what you call the damages we have done in our interest to treat, right? So those are the places where undoing only that will need all these other treatments. So they have to be actually carefully managed. But I think in doing so that you have few important things, like I told you, the leaking start with the fluid scene and the leaking ends when the platelets start naturally rising. So you have to really know where you are. And when a patient comes to you, even though you see bilateral pleural effusion and other things, see what the pattern of the whites, the platelet count, and see whether don't treat a leaking patient, the patient who's leaking is over, like a leaking patient by giving a lot of fluid. That's the biggest mistake that people do. They see fluid in the ultrasound also, and then they start giving fluid. Maybe the patient's fluid is just coming back, and the effects may be that there has been prolonged shock, and as a result of the prolonged shock, the patient may be having organ hyperperfusion and then organ damage. All what you need to do is to manage the liver failure. I
Thank you
don't
very
use
much.
any
It
of
was a
these things.
wonderful.
Yes.
Thank you. Thank you very
Dr.
much.
Lakkumar, Danya, can I ask a
Hello, sir, can
question?
I?
Danya, Dr. Lakkumar, Dr.
Yeah.
Yevle here.
Yeah.
Yeah,
Nice
it
to
was
see you.
wonderful. Yeah,
Yeah.
same here. Wonderful listening to you. I have only one question,
Yeah.
two questions rather. You mentioned furosemide even in leaky phase, a
Yeah.
load of furosemide. What is the
Yeah.
rationale of giving furosemide when the child is leaking and you have not given
Yeah. Yeah. What is the rationale of? I told you.
but then what is the rationale of giving furosemide?
Yeah. I told you the most important thing in managing your dengue is to give fluid during your leaking phase. So if you do something wrong, the most important thing is to undo it. Undo it. Now, I get calls often from my colleagues to say that this patient is we given this amount of fluid and the patient's urine output is low. So they have been gradually increasing the fluid that they give, and whether they have sometimes given extra and bolus also, but the urine output is still not good. What to do? I asked them to calculate the watts, that is how much of fluid you have given on a time scale. Suppose the patient's leaking may be only for 24 hours. Suppose this is a 50 kilogram person and the total fluid quota is 4,600. In 24 hours, you have already given 3,000 ml of fluid, right? So on a time scale, you are heading towards fluid overload. You have already given uh, more than 500-700 ml of fluid in excess. Now the best way to manage is to undo this. The way to undo is to give furosemide. So whether it is at the even maybe 10-15 minutes into 10-15 hours into leaking, maybe early part of leaking, if you are given too much of fluid, best is to give this. You are very sensitive to in dengue to very tiny doses of furosemide. So if you have a low urine output, the first thing I want you to do is, if you are given adequate fluids, if your Watts is close to 100, give 0.05 per kg of furosemide and watch for the next 1 hour, and you will pass a lot of urine, and that will be the end of the problem.
Okay, so in only in those patients where you have given with very
Yeah,
high
you
watts,
will.
you try furosemide.
Yeah.
Okay,
Yeah.
now second question, like is extending Mahesh's question. I mean, specifically in Indian setting, we do see a lot of hyperinflammation in
Yeah.
dengue patients. Probably there is a genetic predisposition. I don't know what it is. So these are the patients where those immunomodulators have been tried here. So do you come across such patients in your country? That was the question perhaps Mahesh was also wanting to ask. I see
Yeah.
Parmanand sitting there. Maybe Parmanand
Yeah.
also
Yeah.
would be. I mean, I leave
Actually
it.
speaking, in this
Yes, you are.
the second case that I showed, there was a physician who did serum ferritin in this patient on day 5 of fever, and the ferritin was high, 44,000. So he was at the first place. You should not even do ferritin if beyond before day 7, right? You should always, because you have HLH like transient phenomenon in most dengue patients. Maybe there's more in people with genetic predisposition. In most, so because of that, it is important that these things are self-limiting. These things are self-limiting. So if you have a patient who is deteriorating, whose fever is not settling, the patient is not clinically well, and then when you do the ferritin and do a second ferritin to see whether it is going up rapidly, not whether, even if it is second, today's ferritin is 50,000, tomorrow is also it is 50,000, means it is not really going up. then be patient not to do any immune modulator or steroid. Just wait. The time will solve that problem.
Okay, thank you. Paramanand, over to you.
Excellent talk. Just I wanted to ask one thing. When you said about the pulse pressure of around 30, to continue maintain that.
Pardon?
You mentioned the pulse pressure of 30 and then
Yeah.
the heart rate increase is low and then dropping the pulse pressure of around 30 from 30 to 20 or 15. Is it, and you are like doing a lot of USG, is it this narrow pulse pressure or that from 30 to 20, is it the myocardial dysfunction which is happening? Whether you look at the myocardium also while doing because in this situation with dengue, so you
Well,
may have myocardial and
yeah,
then there can be a
actually,
narrow pulse
yeah,
pressure and the
actually,
fluid
actually,
management
yeah,
change.
yeah, good question. Thank you for asking that. This about the myocardial dysfunction. People think dengue can produce myocarditis, but actually speaking, dengue in myocarditis has never been proven credibly up to date. Though people have done thousands of postmortems in patients who have died of dengue, inflammation or in the myocardium has almost never been proven. There may be just one non-credible thing, but if you give a lot of fluid, that is one of the reasons why you can have myocardial dysfunction. If you have hypocalcemia, you can have dysfunction, but most of the time your pulse pressure narrows when there is leaking and there is inadequate fluid in the circulation. But for practical reasons, I have actually almost banned our doctors from looking at the IVC in the ultrasound scans and also doing echoes during the leaking phase, because these things can be very misleading and people might give unnecessary fluid on those findings. So I think in the pulse pressure of 30 is needed
Yeah,
for good tissue perfusion, right? If you when your pulse pressure is 20, when your peripheral pulse pressure is less than 30, your splanchnic circulation's pulse pressure is, because when your pulse pressure drops, the splanchnic circulation shuts down and the blood supply to the gut and the liver comes down. And if you have an ulcer in the stomach, that will go into necrosis and bleed. If your liver is perfused with a low pulse pressure, the liver enzymes will go up. So as a result, that you really need to keep the pulse pressure, peripheral pulse pressure above 30 all the time. That's why I say that when it is 25, you need to really intervene and do something about it.
yeah, it's not myocardial, it's maybe myocardial dysfunction with any cause, maybe a shock, maybe the electrolyte calcium disturbances, which may cause this type of problem. And usually in dengue, the other shock which we look at, they have tachycardia. So usually what dengue is have the cardiac heart rate is usually less unless they bleed. If they bleed, they will have tachycardia, but otherwise generally they have low heart rate. So the low pulse pressure, I thought it because of the myocardial dysfunction with and to give little I agree with you the sonography because you have fluid accumulation. The IVC may not be reliable, but myocardial dysfunction can be one of the factors which leads to this narrow pulse pressure. That's what I feel. Thank you, sir.
Thank you, sir, for the excellent talk. Sir, actually, I'm practicing at MGM Medical College with Jitendra, sir, and we have been following your regimen since the past many years. So I just had a couple of doubts. So what we are receiving, we are a tertiary hospital. So we are receiving referrals from other smaller hospitals, and all the referrals are at different times. Some patients are coming before the leaky phase, some are coming during, some are coming later, and they have all received various amounts of fluids which are unknown. So in such a scenario, when we receive, this is what we are doing. I just want to know your inputs. We are starting the patient at 2 ml per kg per hour. And we are looking at the initial hematocrit at presentation, the CBC, and looking at the USG to see for any capillary leak. And for us, what we are observing is urine output is a very, very good indicator. So we are actually following the urine output. As long as the urine output is more than 1 ml per kg or 0.7 ml per kg to 1 ml per kg per hour, we are not increasing any fluids. In fact, we are reducing fluid. In many of the patients, what we are observing is we don't need any fluids at all. So this way, this urine output is helping us to see whether this patient has already crossed his leaky phase or he already has enough fluids. And also, what we are observing is the patients who are out of their leaky phase. We will see that the urine output starts increasing. They start pouring urine. It goes to 2 ml, 3 ml per kg per hour. And this is when we know that, yeah, now we don't need to give him any more fluid. So then CVC we are actually not relying on, we are only doing once a day. So your inputs on this, how often should we do CBC, how often should we rely on hematocrit, and whether urine output can be reliably used to guide fluid therapy.
Yeah, I think if a patient comes with dengue, if there is no tachycardia, if the one of the most dreaded things that you have is if a patient without fever, if the patient is having tachycardia, you should be concerned. You should be concerned. And again, as I told earlier, if the pulse pressure is less than 25, you need to do something about it. But as you say, if the patient is passing enough urine, if the patient is not a diabetic who is polyuric or anything like that, then that urine output is something which is very, very reassuring. And you don't know how much fluid is normally when you get transfers, you don't know how much fluid the other people, there is hardly any information the patient is just sent. So sometimes you may be able to gather some information and ask how much fluid is. If you think that you've given this on my formula of watts, if they have given a lot of fluid, and if the patient is still having the history is like that, the patient is given either oral or IV a lot of fluids, and the patient's urine output is low, what you should really do is to try the test dose of tiny dose of fusimide and see whether there is a response before giving a lot of fluid. Because if the story is like he has had enough fluid, yes. If not, then only you should really think of giving a fluid bolus. As you say, patients come at different stages. So your successful management will really depend on your initial assessment to see where this patient may be. Suppose if the patient's platelet count is 20,000, it is unlikely that the patient is on day 2 of dengue. This may be even the patient who has finished leaking. And one of the biggest pitfalls is people treat patients as if they are leaking at a time when the fluid is coming back, because their leaking is already over. So the sometimes even this can happen. Even a patient who comes at the end of day 3, he may have still finished leaking. So just remember just remember just remember that it is the most important thing that you really need to do. Thank you for kind of what you call following the fluid regime I give. This presentation of mine is also available. I give Danya the freedom to share it with anyone. The whole idea is that people use it.
Thank you so much for your valuable time, and thank you all for such an engaging session. Thank you so much.
Thank you.
So, as sir suggested, we'll put his presentation on the Navi Mumbai group for all to access. Thank you so much. So
Thank
we'll
you.
move
Thank
on
you.
with our next session. Thank you.
Thank you.
Bye, Lakumar. Thank you.
Bye.
Next thing. Which means you have some number. So I have to download the PPT also. ठीक है मैं introduction को उनसे तो ठीक है डाउनलोड दिस करो डाउनलोड एग्जिट करो ये फर्स्ट स्टार्ट कर दो। ये चाहिए क्या? चाहिए? हाँ, किधर गया वो? कौन सा चाहिए? ये देखो, इसको पहले करो। You don't need this. You need this.
So moving to the next session, having the first session on fluid management on daily. The session with three M's. So as the sky is open and monsoon pours, so then that begins our annual bite, our annual battle. Not only with the water logging and colds, but the buzzing vector that is mosquitoes, and which brings yet another oldest infections and disease that is malaria. So I'm sure everyone is noticing the surge of malarial cases in Navi Mumbai. This year more than the past few years, maybe because of the irregular rains or the constructions that are going on. But I think battle is at two levels. One is against malaria and mosquitoes, and another is against wrong prescriptions. Many empirical prescriptions of anti-malarial is being seen. Many wrong prescriptions are there. Many wrong doses are there. So I think it is at most important to keep ourselves updated. What are the new guidelines? So let us unlearn the wrong practices. Let us learn right things from the right person. So I invite our esteemed speaker, Dr. Sridhar.
So we were taught that to check the alcohol levels of the current condition along with the hematocrit. You have a drastic change in hematocrit, you have a drop in the albumin. It's the best thing I would have given is because at that time I'm not going to be taking, of course, I'm not talking about dextran. There is a lot of things about dextran and platelet function, whatever be the type of dextran that you are using. So using an albumin, a 5% albumin. So I just wanted to know from the group, what are your take on?
I second that, sir. Rather than using a text file, it would be not so costly and it will be the better product than the text file and other synthetic products. Critical shock and those patients come in ICU ladder with a severe shock. So albumin is the better choice rather than having a synthetic products. And 5% albumin, as well as those who are borderline MAP, we use a 20% albumin for a period of 6 to 8 hours with slight dose of laxatives.
Okay, just one point. 2014 WHO guidelines have given ultimate next to first two rollers of normal saline. They have categorized normotensive shock and hypotensive shock. When it comes to hypotensive shock, first bolus of normal saline oblique or albumin upfront. The first line of management is albumin in 2014 WHO. When it comes to normotensive shock, it's a normal saline first followed by albumin subsequently. It's already established science. This being the cheaper option, we discussed that. It's not that they have left albumin. Albumin is still higher.
You think Parma, It's a question of what you want to get. I'm giving 5% versus 20%. You're deciding, I want now, so the 20% if you're giving, it's a like osmotic pressure, it will reabsorb more fluid, more cardiac dysfunction, and other more allergic reactions. 5% slope over a period of time is acceptable and you take. So it's a free biologism and such. I mean, you look at it's not only getting improvement, multifactorial. So how long the patient is leaking, how much is the fluid loss? If it is full of cycle, ultimately is not better, but slow infusion over a period of time. Based on what Sir was talking about during boluses, it won't agree. Because most of the fluid fluctuations will occur in this, if it is slow absorption with albumin over a period of time, it maintains the oncotic pressure little high and it will reabsorb the fluid and then you give Lasix as an infusion and get rid of the extra. What Sir was talking about was the volume of the status. So if you look at it, fluid retained, more than 15-20% of the volume retained in that situation, how to get rid of that volume. Because if you're giving chlorides, it will lead to acidosis and cellular dysfunction. So it is not that albumin or something, it is optimal use of albumin definitely helps in that situation depending upon what is the clinical scenario at that. Right, very good.
But only in certain situations, like we are practicing at a medical college, so there we are able to use dextran because aluminum is not available. It's a costly drug. Even those 3,000-4,000 patients are not able to afford. They are absolutely, I can't pay a penny type patients. So there we are giving, and we have been using this resolution. We hardly need to use dextran once a week, and we have 60-70 admissions per month. So it's a heavy center. So hardly if you're giving fluids appropriately, hardly one or two people in a year will require extra. Otherwise, even our experience with extra is okay, but only in cases where we cannot afford aluminum.
What the false question? Pericardial efficiency. Would only be looking for pericardial effusion with counter pulse pressure. Everybody was talking about the myocardium. See, even if the pericardial effusion is not going to cause fluid, if it is a cardiac tamponade, it is going to cause the pulse reflux. If it is not, then even the infant. So it is not a dominant. If it's a mild pericardial effusion, it is going to have because of hypertrophy. Moderate to severe one, if it is not causing cardiac dysfunction or the cardiac contractility is not getting affected, it is not a tamponade, it is going to get reabsorbed and through the depth of the urine over a period of time in a recovery phase. The focus you would include. It is there. That's what I'm asking because what happens is it's a narrow pulse pressure, it is 30 to 20. So if your cardiac output is not good, so the body response itself actually to increase the catecholamines, which is going to narrow the pulse pressure. So from 30, if it is dropping to 20, I am more worried about leakage and or the cardiac functions is not good. If it's myocardial dysfunction or myocarditis, the cardiac output is less, the pulse pressure is going to be narrow. In fact, if there is a leaking, what happens is your catecholamine response is not good enough at that time and it becomes a decompensated shock and you have a wide pulse pressure. And I am worried about the dengue where there is a wide pulse pressure and there is more leakage and absorption. So in there, giving a fluid to maintain the optimal pulse pressure also is a tricky. And there it's a question of giving colloids, maintain the optimal because the volume of fluid which you are going to give, whether it's a blood, whether it's an albumin, to maintain the oncotic pressure and get rid of that extra fluid. Otherwise, you are going to cause more problems with ventilation issues. All those are going to get complicated. It's just one point. We used to do an ECG, look for STT changes, do a focus, look for pericardial effusion, and then think about the pulse pressure.
All the pulse pressure, you see all four categories of shock that we deal with. You're getting late. The hypovolemic, the cardiogenic, the obstructive, and the maldistributive. Of which only maldistributive has the right pulse pressure because of education. Remaining all three, hypovolemia, myocardial dysfunction, obstructive, and your myocardial fluid, pericardial fluid gives us the obstructive shock. All of them are having narrow pulse pressure. Unfortunately, in daily, you can see all four, including vasoplasia. What Parman just now said is a vasoplasia, which is like a septic shock. We have seen all categories. So just based on pulse pressure, I believe it cannot, and especially we should have an IVP line to monitor that pulse pressure. Clinically or NIVP becomes failure in that scenario. So that's a lot of limitation. And if you look at daily guideline of the WHO, they monitor 20 millimeter per square, so not 30. So 30 means you are just kind of keeping it very safe, which is not always possible in daily.
When the vasoconstricted NIBP is not there. Absolutely. There's actually one by.
Yeah, sorry, I just thought that a few things have to be cut off from my presentation. Okay, even though you may be very small and insignificant, you do have a big bite and you can create a lot of trouble. That's the mosquito. So we are going to be dealing in the three M's. And what I'm going to do is I'm just going to be generating interest on this topic. Okay, and as far as therapeutics go, and whatever queries you have, we have a lot of ID consultants down here, Danya is here. So I think they are the right people to talk about.
Is it?
Okay, so malaria is one place where you have all types of medicine. So today, when you look at medicine, you have acute medicine, you have preventive medicine, you have revolutionary medicine, and there are a number of branches of medicine. So malaria could come with renal failure, could come with ARDS, could come with coma, could come with seizures, could come with a septic shock, could be algic malaria. You could have an Addisonian failure and shock. So under the umbrella term of acute medicine, malaria fits in very well. Evolutionary medicine, and we know about that. Probably the areas where we used to see a lot of malaria is where we see a lot of all these hemoglobin aberrations. So we do see hemoglobin sickle cell is something which is very common. We also see G6PD. We have seen the Duffy antigen. We have seen a predominance of the O group, and all these give you some sort of a resistance to malaria. And then if you get into preventive medicine, now we have the two vaccines that are coming to the market, the one by GSK, the first one. And they do, because what happens is if you get infected, I mean, if you have even repeated infections, all that you get is the severity comes down. There is no sterile immunity. So we are trying to reach sterile immunity by two vaccines which may have to be given repeatedly beyond 5 months of age, and there are two now in the market which are being tried out in African countries. And we all know about iatrogenic yes. And this started off with mefloquine. Okay, so we had mefloquine being given every week and neuropsychiatric suicidal tendencies. And it's only over a period of time that you get to know what could happen with a particular medicine. So we are seeing it with oseltamivir, we are seeing it with the Montelukast, and we used to feel that no, the patient is improving. That's why the changes in behavior, but no, we are realizing so much. And when you take anti-malarials, you need to know cardiac toxicity. You can have neurotoxicity. You should have something to the eye. You can even have a type 1 type of hypersensitivity reactions, even with something as simple as an artificial. So you need to know this before you jump into it. And any drug with a prolonged QT, like suppose this child is on clarithromycin and you're going to be using an anti-malarial, you need to think twice. And some of them are inhibitors of various cytochrome systems. So when you have inhibitors like lumefantrine could be an inhibitor of the cytochrome system, like for example CYP2D6. And in all the medicines that are metabolized, you need to have that complete list because one dose is enough to inhibit the enzyme and bring up the dose. And let's get into preventive. So how do I prevent and why is it that we are seeing so much of malaria? I think it all started out in Gabon. And we used to learn our malaria from it was the construction, the storage of water, the occupation of the flat low-lying areas, which is not to be done. And we all do know that nowadays we have these cloudbursts. So you have a torrential rain for about 2 hours, excellent governance by the BMC and local, so you don't know what to do. Where the moment it starts pouring, you rush back home. And we are all educated, the so-called coconut shells and kayaks.
So there is much more to be done because almost all the waterlogging is, I feel, is because of all those big flyovers and the water draining into all those small puddles, and you have more problems outside than inside. But again, it's a money-making thing. The BMCU comes home and shows you larvae at different places and you're supposed to pay attention. Yeah, the coastal road. If you read all about the coastal road project, you will be amazed to know that this has contributed very significantly to climate change, to all sort of diseases, including malaria. So don't encroach into low-lying flat areas. And the problem with new constructions today is all the drainage gets into the main stormwater drain. You're not supposed to do that. So obviously, when you have a high tide, then water is going to seep back into your place, you are in a mess. Intermittent rains, high humidity, water loss, all prolong the life of a mosquito. So we are responsible in a way to increase the malarial population, and right, we are being taught to coexist, but not at this level. So I'm going to be discussing the main playmakers, a little bit on the disease, diagnostic limitations, and a little bit on therapeutics. And if you have more queries, we have multiple experts here who can tell you about what is to be done. So it's going to be the mosquito, the host, and the plasmodium. Not much about the female Anopheles. It's not that I'm an anti-female, I mentioned female there, but the female bites. Okay, and the male, I'm talking about the mosquito. Yeah, so the female bites and the males are more for the nectar. Okay, and they need the blood because for reproduction when they have the baby. Right? Okay, so why is it that some people are bitten more than others? And we have multiple studies. It's basically the volatile organic acid, fatty acid oxidation products that come from your body that makes you more attractive. So if you have more of carbon dioxide around you, lactic acid, all these big molecules, the mosquito likes you. So you are bitten by the mosquito when you are perfect, whereas your other friend is comfortably seated. So what is now being done is they are trying to pick up all these things that make you attractive and the ones that are inhibitory, and they're trying to make creams out of. Okay, so you could have a repellent with all the muck that you produce on the stick. How many of you all have heard about the gene web? Now we are manipulating the genome of the mosquito. Okay, and this is amazing. And it has been done to such an extent that the males have been manipulated, as usual. Okay. The males are manipulated and they are being released in two places. One is Florida and the other is Brazil. And we are waiting for the studies. When they copulate with the females, you produce a group which don't survive for long. The males survive, the female perishes. Or if they get dengue, Zika virus, or a plasmodium, they cannot survive much in those muscles. So it's something amazing. This is all because of the gene scissor, what is known as the CRISPR-Cas technology, and it's being done in a big way. And we are just awaiting results. The other thing which is very interesting is just like we talk about microbiota, they also have a microbiota. And there is an organism called Wolbachia. You should read about insects and Wolbachia, how they can manipulate the reproductive system. It's amazing, and they are doing studies on that also. Fish, they have been used for ages in all these breeding points, the Gambusia ones. And now we are looking at, it's not Bacillus clausii, but the bacilli from the sewage and fresh waters. They produce certain metabolites that can finish off the larva. So they are even trying out those supernatants in breeding points where you cannot do much. All types of insecticides. Okay, and now we have resistance to everything. They are also smart. Just like we evolved, they also evolved. And they are extremely smart. So now we have started using combination. So it's not just pyrethroid, but we use pyrethroid with the chlorphenol, or we use it with the BPO. And that makes it, so we have these nets which are impregnated. The Indian Army was using nets impregnated with neem oil. It's found to be very effective. And what they are now using is nets wherein if the mosquito goes and sits on the nets, it makes it a little bit more susceptible to an early death. So there's so many things being done, and the Bill Gates Foundation is something that's really pouring out money for all this. We all know about the citronella. So every patient comes in with an odorless. So initially it was all DEET, extremely toxic. But now you have the citronella with aloe vera. I think it's called Odomos Natural. I'm not trying to sell something out here. But you need to understand just like you have a half-life, it lasts only for an hour or two. So you need repeated applications. You can have photosensitivity with it, just like neem. The neem face wash has a lot of photosensitivity. So you need to know the other side of all these oils. And there are a lot of people who use the lemon eucalyptus oil, put it in cotton, and put it in the four corners of your consulting group. It's quite a good effect. So elimination techniques, we have used insecticides, we have tackled breeding grounds, genetically modified mosquito, the marine bacillus, Wolbachia, and fish. Now let's come to the plasmodium. So you have a vivax and falciparum that occupy the top stage like Amitabh Bachchan and Shah Rukh Khan. And the rest, if you see the names out there, malaria and ovaria are coming back in a very big way in Orissa. It's a big pocket. And if you see the ones in the white, they are the ones which are jumping from the monkeys to humans. So we know less about Nolesi, but it's there in the market. And the new ones are cynomolgi that has come in India, and we also have the CB. And we have always been taught this. So when you have a plasmodium tackling retics or the young RBCs, you end up with anemia, which is more prominent, especially the vivax. When you have the malaria affecting the mature RBCs, you know that the tendency for an antigen antibody complex and deposition in the kidney, and we were taught one of the cause for nephrotic syndrome used to be Plasmodium malariae, and the falciparum, the notorious one. So it's not bothered about who you are, what age you are, and they tend to stick everywhere. But now there is a lot more in this. And what is new is you just type extracellular vesicles and malaria. Very interesting topic because today extracellular vesicles are discussed in every possible pathogenesis of every bad condition. So these are membranes, outpouchings from RBCs, from immune cells, which are causing all the problems. So they will now be used as biomarkers. They're also going to be used in therapeutics. They may even be used for multiple other things or even for targeting the disease. Then we also need to know that we only knew a little bit about malaria getting into the liver and sleeping out there. They were called as hypnozoids. But now we know they also have niche in the bone marrow. They could have a niche in the spleen where they could be lying dormant. Just like now we know so much about tuberculosis. And we all know this life cycle. And why you need to know this life cycle is because therapeutics depends on understanding the disease. So when you look at this, okay, so when a mosquito bites you, a little bit of these sporozoites are deposited on the skin. It could be a few to 100, and they get into your stream, get into the liver. Once they get into the liver, they multiply and then they come out in a big way and then affect the RBCs. Then you have these two essential cycles, which are very important when they multiply, and the numbers are almost reaching up to 10 raised to 13. A phenomenal number. So any drug that can affect these two asexual cycles right in the beginning. See, malaria is very funny. The human host is not sexual. The mosquito is sexual. And the gametocytes are produced in the humans. You have the early gametocytes and the late gametocytes, and the mosquito needs to pick up the gametocytes to continue the cycle. So you need to know your drugs that work on which are sezonticidal and which work on gametocytes. So the artesunate and the artemisinin, even though we keep pointing a finger at China for every possible thing. All the artificial derivatives that come from China. Something amazing. Talking about host, I told you the immunity is very incomplete. We don't have a stabilizing immunity. So if I get 3, 4 episodes, yes, I may not get a severe episode of malaria, but I'm not immune. Less than 5 years are the ones who are affected the most. And also in pregnancy, because it's an altered immune state, because the mother has to keep the baby with her. HIV is another thing. And the problem is all these rural posts or the rural areas where you find maximum malaria, these are the places where the access to healthcare is a big question. Even if you have access to medicines, affordability, availability, everything is an issue. Geography and power. So let's come down to diagnosis. Just like ultrasound is operator dependent, microscopy is not only operator dependent, and you want that operator to have enough time to go to the. Unfortunately, today when you go to a lab, the urine routine, the stool routine, the CBC, everything is last on the priority list. And they're all kept there. So ideally speaking, you need to do a thick smear and a thin smear. Thick smear because the amount of blood there is much more. So the chances of finding out who's there is easy. So oh yes, there is a malaria sitting there. And a thin smear is to identify who it is, whether it is a VIVAX or a falsifier. That's the way it is. And if the parasitic count is very low, you need to repeat it. Okay, so you need to repeat it 12 hours or 24 hours after doing the first one, where the clinical suspicion is very high. Then let's come down to antigen detection. How many of you all do antigen detection and microscopy together? Okay, so majority. But what is happening today is the antigen detection depends on the kit, KIT. So you have a 1 rupee kit and a 1,000 rupee kit. The 1 rupee kit is a kit. You need to understand this. Okay, and the kit, expiry date, everything is very, very essential. And in the kit, what I am trying to do is pick up some of the markers of that particular organism. So you have a histidine-rich protein 2 and 3, or you have an aldolase or a lactic dehydrogenase. All these are picked up on a strip, and you require femtoliters of blood just to get it. So it could be a dipstick, it could be a catheter, and the turnaround time also is extremely short. So it's amazing. But what is happening is the mosquito also has become smart, like I told you. So they have started deleting off their histidine-rich protein 2 and 3. So when you don't have that marker on your body, how do you pick it up? You can't pick it up. And this is being seen in places like Orissa. And now we are seeing that a significant number, even in Africa, are getting these deletions. So even though they are very useful, but you need to know about these deletions. And the other ones are the pan ones, where they are there. And they are helpful because you can start off therapy very early. Just like in tuberculosis, suspected tuberculosis and used to start when we were residents. But now the teaching is you have a definitive diagnosis before you jump into medicine. Same thing, we don't want resistance development. So that is a little bit on rapid diagnostic tests. Then we have molecular diagnostic because today everything is nucleic acid amplification test. Thank you, Dania. Your article was very useful. I had to call her up because I just wanted to know what was new in malaria. And the lab, which has now come in and had a lot of nucleic acid amplification tests. And have you heard about the Google glasses? It's going to change. It's going to change many things. So I have a slide, and I look at the slide with my Google glasses. I can get a report done without being a pathologist. And the error rate also is almost negligible. So you make a smear, wear your Google glasses, use your AI. There you are. Yeah, it's something great. So if it comes into the market, it's going to be good. But you require, these are all corroborative evidence. You require clinical and then you are investigating. Then other than lamp, what is very interesting, these are the places of HRP deletions. So that's why when the suspicion is very high and you still have an RDT which is negative, the other side of RDT is within 5 to 6 weeks of a primary infection, you still have it circulating in your blood. So when you do a repeat RDT, it may come positive, even though you don't have it. Fine, you need to know that. This is something which is coming in a very big way. So what happens is when a malaria gets into a cell, it uses up the hemoglobin. And when it uses up the hemoglobin, you're going to create a pigment called hemozoin. And the ICMR, the turnaround time of this is 1 minute. You just require a battery, that's all. So you create a magnetic field. So the hemozoin has iron. So the iron is arranged in a particular pattern and it prevents light from being transmitted. The moment you pick up hemozoin, you know malaria is one only thing which produces that. So you know malaria is there. And now they are trying to find out, based on hemozoin, which malaria is there. So that's amazing. And this is being used in the remote rural areas and ICMR projects. So coming down to therapeutics. So one drug which is used, overused. I would never call it misuse because as pediatrician, I know my problem is diagnostics. I don't have diagnostics on a chip. And I don't have cheap diagnostics. So most of my treatment is based on the clinical scenario and common sense, which is again lacking. So what we need to understand about artesunate, an amazing drug. But don't stop off with just one dose. We require minimum 3 days. Like I told you, the asexual cycle, the first 2 days you need to tackle. And then you get in whatever combos you would like to get. And the second thing that I was discussing with Danya, and she was trying to tell me, you need to tell the audience is, let me ask you, how do you prepare artesunate? Anybody?
Soda paita, we not diluted in the food and we will leave it as a push.
Yeah. So thing is, you have 3 ampules there. So one is artesunate or 60 milligram maladaba. Then the other one is a soda bicam, and the third one is a normal saline. So what you do is you put the soda bicam and then you shake it very gently. Don't create a froth to it. So gently shake it till it is absolutely crystal clear. If it is turbid or altered color, please discard it. Again, it is like the cake. You need to see which company is producing it. Okay, buy only from an authorized good brand because these are all life saving and they have to be given at the right time. No delay. So you first add your soda beta and then wait for some time. Then you put in your needle and syringe again. Remove all the possible air. Why you need to remove air? Because you need to put in saline now. You require space there. So you have a 5 ml saline which is then added. And this is for IV. If you're going to give IM, you're going to add only 2 ml of saline. You can't give 6. It's painful. Okay, so you're going to use, so you need to calculate your dosing. So whatever it is, 2.4, 3, 4, whatever you're going to be giving, according to whatever schedule, you need to calculate that. Then you need to give it by a slow push. Okay, and you can get reactions. I'm not saying any drug can give rise to anaphylaxis. So see to it that you have your basic medicine for anaphylaxis, that is adding. So that has to be there, and there is no role for an Efcorlin or an adding. Okay, so that's one. Second, it seems that a lot of people still giving it by an infusion. Please don't give it by an infusion. Don't put it into your bottle that's for you. Then, at the end of 3 days, when you're going to use a combination, and know all your combinations. What do you need to know your combinations? The first is a mega kill. What is a mega kill? It's almost like dropping a bomb and finishing off as many as possible. And the kill rate of artesunate or artemisinin derivatives. First is artesunate, artemether. When we started off in 89, we had arteether as an iron injection. We used to give a big dose first and then small dose. Then it came, you can't use it in children. the absorption is a bit erratic, oily injection. Then we have Arthur now, and there are so many new ones coming into the market. But you need to understand that the kill rate is phenomenal with all the artificial there. They almost finish up. So what is remaining is a few of them which can still continue the exoelectrocytic cycle. And the gametocytes also, the early gametocytes are finished off by artificial. So even a feeding mosquito is deprived of the gametocytes. So once you finish off, you require a companion drug. A companion drug is only to be supported. Whoever is left out. Now you have finished off the main, you send in your helicopters and your soldiers get down there and you try to find out each one I hit. So if you're going to use an artimeter lumefantrine, that's the way it is. So the lumefantrine, but again, you need to know everything about a drug before you prescribe. So if I'm going to use artimeter lumefantrine, what is the first thing you tell your patients? So you offer them that particular syrup or tablet with a basu, with an ice cream. Wow. All these wrong things are given when you're sick. Yeah, but a fatty meal is very beneficial because 1 rupee, 10 rupee. The bioavailability goes up phenomenal. And you finish off the course. Don't stop it. Follow the instructions. That's something very important. So even the chloroquine resistance that we get probably was because we used to do anything and everything under this. It needed to be 25 milligram per kilogram as a total dose. Whether you gave it 10, 5, 5, 5, or you gave it 10, 10, and 5, finish off that 25 milligram per. Wonderful drug. Even today it works in all chloroquine sensitive areas. And remember, the vomiting in malaria is because of malaria, not the drugs. Okay, that toxicity of malaria is the one that is causing all the vomiting. And this is just to show you where most of the drugs are working. And why is it that you need to give combos now? It's not only for prevention or generation of resistance. Because see, what happens in a mosquito or in a plasmodium is there is something called as you die when you start mutation. There is a price to be paid for mutation. Okay, so they usually don't take to that recourse. And every organism just wants to survive. They don't want to kill anyone. Look at Corona. They killed, they established a niche, and now they are at a low level because they want to continue. Fine, so that's the way it is. Same thing, this is a better slide wherein you see everything. There are a lot of new drugs like the big brother of primaquine, which has come in called as Tafenoquine. This is again not in the pediatric age group, but it's now coming back in the pediatric age group, which is about 16. And which is basically because when you're going to be dealing with hypnozoids, the ones sitting in the liver, you need to give primaquine. And we usually do a G6P. Fine. And whether it's a male or a female, please do the G6PD because we are in an era of safe medicine and we don't want trouble. All the combinations. So when I started practice, this was in 89. This sulfa-pyrimidine combination was the thing because it was a single dose. And what used to happen is you take a dose and you get bone marrow suppression. Same thing happens with autism. You can get reticulocytopenia, you can get neutropenia. Remember, why I'm trying to tell you? Because in our basket, I have enteric fever. So when I see low counts, viral, enteric fever. So you need to know that these were the drugs that they're antifolate. So naturally, there's going to be suppression. So make it a point to write on your prescription you have given this and just don't tell them something on the phone because the next doctor who's going to be treating will at least know, no, they have taken this and probably that could be the reason for the low counts. You want to add something on all these combinations? And this is something you need to understand. Like I told you, artemisinin goes in and comes out. Okay, it's like Operation Sindhu. Yeah, you just go in and come out, and you still don't know why they came out. Okay, but here we know why we are coming out because we want efficacy. and we have something to continue. So you just go and finish off, see the half-life within an hour. So artemisinin just is so short-acting, and then it's out. And then you continue it with something else, so a lumefantrine, which has a longer distance, or a natrovactor, something of that sort. And even the chemoprophylaxis, you have two categories. One, which have to be started 3-4 weeks before you travel. Some which you can start up 2 to 3 days before you travel, because sometimes you don't plan. And when you don't plan, you need something if you're going to an endemic. And just to, no, so that there's a little bit more color so that you won't forget what is being used for what. Thank you. But there is a big question mark out there. But today it's all coexistence. Okay, when somebody goes out of hand, you're a bit scared. So what they did is, in a place where there were too many rats, they let snakes in. The rat population came down drastically. But the snake population went up to such an extent, now they are offering money to catch snakes or kill snakes. So there are enough such stories. So you have to coexist. Second is DDT. You all know all the stories about DDT, the bald eagle, how it started declining because of just DDT. So everything has a collateral effect, and there is another side to it. Everything should be done in moderation, but when something is killing, you can't sit and watch it happening. But definitely, we could stop breeding sites, and we could. Cleanliness is next to godliness, and just like we take care of our house, we need to take care of our surroundings. Thank you. Thank you, Coach.
Sridhar sir, for this wonderful lecture, especially the updates which we got. May I request Dr. Moradwa sir to participate, Dr. Sridhar? Thank you, sir.
I think that's good.
We have very long association with your father. And sir, right in the beginning, I mean, it's been a long story.
Yeah.
Yes.
Actually, unfortunately, yesterday we lost one genius teacher of our population, right? Why I recalled me because we always believed he was different. From his IQ level, from his intelligence level. That's a very different lineage in IIT. And be the next person in that lineage. I always you know something beyond. It's a most difficult topic, so interesting and easy. Look at the way what you said. See, I used to get a feeling with Dr. Ashim.
So it's me, check final.
And they,
So check final.
he reads a lot and he remembers too.
It's full screen.
But I think we are seeing this trend of buyback material is located in ICR and responding to growth queen buyback to just take home metrics that will increase work here. Thank you. So we have another excellent speaker who has agreed to come here in Navi Mumbai, who is consultant pediatrician and an ICU in charge of Ashwini Hospital in Solapur. And he's extremely well known for his clinical skills. He has a huge collection of different clinical cases, history of any infection. And when we had this outbreak of chikungunya in Pune and areas around, he was the go-to person to ask what's actually happening because there were so many unusual manifestations of chikungunya.
So we were wondering whether the virus had mutated or whether it's just the full number of cases that have gone up. So he has all the answers to these questions. And thank you once again for us to come all the way from Surat. Thank you so much.
At the outset, I thank Dhanya and President Navi Mumbai Association for inviting me for today's talk. And further, as usual, as I said, wonderful talk. I'll always like to hear you. This is a really nice talk. Today, I'm going to talk to you on chikungunya, another vector-borne disease. Let's start with the case scenario. A 2-month-old male child presented with fever irritability for 2 days. On examination, there was tachycardia, CRT was delayed, and there was flushing. This is the picture of the child. You can see my fingers, there is flushing and also CRT is delayed. So 2 months child, post-monsoon season, high fever, irritability. What comes to our mind? First thing, dengue. Yeah, dengue is the first thing which comes. This is called erythroderma or flushing. As it can see in the other viral infection also, but dengue is one thing where you get a classical erythroderma. What are the other conditions in which you get a erythroderma? Classical, they present with erythroderma. Toxic shock syndrome. Toxic shock syndrome can come with erythroderma. And third thing which I am going to talk is the chikungunya. Also in the flu also we get erythroderma and some other viral infections. But these are the serious conditions which we have to pick up with these flus. So on systemic examination there was nothing. That was irritable. On investigation there was a thrombocytopenia. CRP was raised and NS1 was done, it was negative. So on day 4, what has happened? What is this? Bullous lesion. So with this clue, we send chikungunya PCR and it can see positive. So this is one of the vesicular lesions, which is one of the skin manifestation of chikungunya. This we have to remember. And this was that baby's mother. She had a body ache fever 3-4 days back, and she had a flushing, and you can see the red ear, and there was edema over the ear. This is called million ear cycle. So mother had chikungunya 3-4 days back, and then the baby had chikungunya. So this is the baby's photograph. So this is a arthropod-borne disease. It was tropical disease only, but now it is seen all over the world. So you can see all over even in the US, the chikungunya has gone, and though mortality is very low, mortality is there in neonates and elderly persons, but in usually healthy persons there is no mortality, but morbidity is very high, especially in the adults. If they get chikungunya, they become disabled. It may cause chronic arthritis, and you may have greater morbidity and loss of human productivity. This name has come from Mokonde language, which is called Kungunyala, means become contorted or the scooped up posture due to joint pain. Sometimes what happened in 2006, we had a big epidemic, and at that time, sometimes there was sudden immobilization. So elder person, they have went to the toilets, washrooms, gone inside, sit there. After doing there, they are not able to get up from there. So they have to break the door, call the Daya to open the door. And this happened many places. So this is typical sudden immobilization. This is one of the presentation of chikungunya, and the name is because of that stoop posture. It was started usually in the African countries, 1952 in the Mokonde, and initially these outbreaks were treated like a same as a dengue, but a virus was isolated in 1952. There were large outbreaks with high attack rates, and most of the outbreaks were initially in the South Africa and the Kenya, and after 52 to 62, there was a gap, and in 2006, again there was a big outbreak all over the world, especially in Reunion, Iceland, then Asian countries. So there was a cyclical movement of this disease. So in between, they disappears and again comes as a recycle, re-emerging infection. So what about India? In India, it was first outbreak was seen in 1964. Then in 1973 in the central part of India, in the Nagpur, and 2006 it was silent, and 2006 National Vector Control Board has approximately 1.36 million people were affected. Out of it, half of the Karnataka and one quarter of the Maharashtra was affected. As our area Solapur is near to Karnataka, we had severe epidemic of chikungunya in 2006. And after that, we are getting yearly also sporadically. So this is a graph where you can see the cases 2014, 2015, again 2016. Delhi there was epidemic. Bombay you had chikungunya 2 years back. No? Huh?
Last year.
Last year. But
Not yet.
Not like what you have Guna had. We
Yeah.
didn't have that bad.
period. So it is a highly cytopathic virus. It is a alpha virus, single stranded RNA virus. I will now go into the details. So transmission, as said, the main vector is Aedes aegypti. Already Sridhar has explained how it transmission occurs, and Aedes aegyptus. Aedes aegypti is the better vector, prefers to live in the people and bite painlessly. That is very important, and it bites several people in a short period of time. So in one family, you get a 4 or 5 people affected. And most commonly in the many times we have diagnosed that mother is having flushing and they have come baby with a high fever and crying. So chikungunya, the same the infection is for mother and the baby. It is the Avilutus, it is called a tiger mosquito, most commonly seen in South Asia. Another important thing, these are co-vectors for dengue and chicken Zika. So we have to differentiate because the same climate, same vector is there. So and presentation is also same, fever and rash. We'll see how to differentiate. So transmission, horizontal transmission between the mosquito, vertical overall transmission, what is called in the occurs in the very harsh condition. Then transmission to susceptible humans. Then human to human transmission, not yet described, but virus can remain in the semen for 30 days. 30 days. Then vertical transmission, we have seen early pregnancy may cause miscarriage, then perinatal transmission called neonatal chikungunya, and no transmission through the breast milk. Blood products, it has been described solid organ transplant, blood products, but solid organ transplant not described. Pathogenesis after mosquito bite, it enters in the skin and there occurs a viremia. And these injected viruses enters into the dermis and there are occurs of viremia. Viral replication occurs in the connective tissue, especially in the epithelial cells and fibroblasts. And most of the monocytes are responsible for this blood dissemination, and they target mainly muscles, joint fibroblasts are mainly targeted. So they affect the joints, especially like of rheumatoid arthritis. So what are the clinical manifestations in acute phase? Majority are symptomatic. Whenever you get a bite into Monsoon 90 around 90% they get a fever, 90 to 95% of the fever. But it may be 1 or 2 days fever also, or few hours fever, and then there occurs a very important thing is the immobilization or joint pain. That is very common, especially in the adult or adolescent children. But in small babies, they have extreme irritability while moving. While sleeping, they are quiet. Once child get up and moves the limbs, and child starts crying because of pain and fever. And third is the rash. So triad of fever, rash, and arthralgia is very common. Uh, Sudden onset illness, febrile, myalgia, fatigue. What happens? Sometimes they get fever, and the next morning they are not able to walk. They are not able because peripheral joints are involved. So for 2 3 days they are not able to walk. Flushing is there, and that is the classical sign of chikungunya. Fever usually lasts for 3 to 5 days. Sometimes now last year we had many patients lasting fever for 10 to 12 days. And chikungunya IgM came positive. They had rash, fever without focus, all except CRP and leukopenia. All tests were negative, but blood cultures were negative. But fever lasted for 10 days and some joint pain. There is usually poor response to the antibiotics. Arthralgia, polyarthralgia, as I have told you, peripheral joints are involved, and there can occur severe immobilization. Typical children's, this arthralgia is less, 30%, but in adult it is more than 70 to 80%. Cutaneous manifestation can be seen in adult. What we see in the children, maculopapular rash, flushing or erythema. You can see the flushing of the face and median ear sign, red color ears. Then you can get hyperpigmentation. Centrofacial lesion is called a chick sign. You can see the pigment. This child was initially referred by dermatologist to me to rule out some endocrine cause or something. But when I asked the history, mother had severe pain, arthritis 4 5 days back, and this baby had this type of pigmentation. Did the chikungunya IgM came positive, just treated conservatively. After 1 month, pigmentation disappeared. This chikungunya virus during the inflammatory stage, it stimulates the melanocytes to cause this pigmentation. Then you can sometimes get as well as the millennial sign, there is edema of the cartilage and ear. Then acrocyanosis is also common, especially in the newborns. Severe vesicular bullous lesions in the infants. This was the 12 years child, had a fever for 2 days, taken oral the drugs, and came with this type of rash. We did chikungunya PCR, it came positive. So you can get these vesicular bullous lesions also. But they are more common in infants than in older children. This is a purpuric achromatic rash. Then bullous lesions. This is again another child had severe bullous lesions. So and non-healing ulcers or even mouth ulcers. We have seen gum hypertrophy also in many children. Hemolytic manifestations rarely can occur. You can get some GI manifestations. Other like asthenia, severe weakness, cervical lymphadenopathy in the few children we are seeing. This CNS manifestation initially they are thought to be very mild disease, but this region island and Indian epidemic from 2006, there are many cases affecting with status epidemic complex seizures and encephalitis. Usually, those children who suffer from chikungunya encephalitis, they have a long-term neurological deficit. Then polyarthralgia, you can get this type of arthritis. This is more common in the older children and adults. This chronic, what we say, the chronic, when acute phase is less than 3 weeks, 3 weeks to 3 months is the subacute phase, and chronic phase is more than 3 months. Polyarthralgia, it can be chronic polyarthritis or flare up of pre-existing arthritis. I think Vijay is here. These patients, we have to refer to Vijay for the management, because this chronic arthritis as such is uncommon in pediatric, but older children, we have seen few children having chronic arthritis. Other uncommon manifestations like hepatitis, nephritis, myocarditis, GBS, neuropathy, meningoencephalitis, ophthalmic uveitis, and total alopecia is also reported in the chikungunya. Another case, this 26-year-old second gravid mother had a normal vaginal delivery. Baby was normal, cried immediately after birth, no significant history. Only baby mother had a history of fever for 2 days and mild thrombocytopenia. So she was treated like a viral infection, and she settled down within 2 3 days. Baby was also normal for 3 to 4 days. Then baby was discharged. After going home, fourth day baby had a fever, then refusal to feed, breathing difficulty and convulsions. And they got outside, admitted to outside in ICU with a convulsions, fever. So treated as a sepsis, started with antibiotic IV fluid, but baby had continued convulsions. So baby was referred to us. Baby was on admission was having respiratory tachypnea, convulsions. Baby was in status. So this baby required intubation and anticonvulsants, antibiotic we have started. Initially, we were thinking that this is sepsis, but CRP was 60. Counts were showing 15,000 count with thrombocytopenia. So this was the counts. So we started with higher antibiotics, vancomycin and meropenem was started. CSF was done. CSF was showing 15 to 20 cells lymphocytes. And MRI was done in this child. It was showing degenerative, query with the degenerative disorder. So child was not responding to antibiotics, but with the supportive management, convulsion stopped. After 8 to 9 days, we could extubate this child. After extubation, when I saw the child, there was pigmentation on the face. So retrospectively, then we thought of chikungunya in this children. So we did IgM, chikungunya IgM, it came positive. Mother also chikungunya IgM came positive. So this was, you can see the pigmentation of the abdomen, face, peripheral pigmentation, and this is the chick sign. And mother's chikungunya baby and mother's chikungunya also IgM came positive. So this was neonatal chikungunya or transplant chikungunya with encephalitis. Now this baby is around, this is 2020 case, 5 years old, having severe neuro deficit. So most of the chikungunya encephalitis, they have severe neurological outcome. So this, so in neonates, when there it can develop the neonatal chikungunya because there are insufficient antibodies in the mother to get neutralize the viral viruses. And it was reported in 2005 also. In 2005, I have seen 4 to 5 neonatal deaths. Mother had a high fever, they did and meconium stain, so they did C-section. Baby cried, severe tachycardia, went into probably cardiac failure and expired. I have seen 3 babies. Probably it can be a myocarditis. But at that time, we were not able to prove that other things. But 3 to 4 deaths, I still remember after section within 24 hours, baby died. So it can be a neonatal myocarditis because of chikungunya also. Manifestation neonatal period, as I already shown you, bullous eruptions, then flushing, tachycardia. They used to come with high grade fever, flushing, and tachycardia, heart rate of 190 to 100. Then pigmentation. So these were the neonatal presentation. So difference between children and adults. Pigmentary changes are more common in children as compared to adults. Oral ulcers are more common in adults. Then hemorrhagic purpuric complications are more common in children as compared to adults. Myalgia arthralgia is seen in 30 to 50%, where in adults it is 87 to 98%. And chronic arthritis is more common in adults as compared to the children. CNS manifestation, encephalitis is more common in children as compared to the adult. Headache and encephalopathy, they are seen, but the incidence is very low in adults. So healthy adults, usually it is the morbidity because of arthritis is more common. Clinical outcome usually resolves within 7 to 10 days. Mortality, previously it was thought that there is no mortality, but in immunocompromised neonates and elderly, you can get sometimes mortality also. Uh, so, differentiating features. Differentiating between the dengue and Zika is very important because of same mosquito, same clinical features, and circulation is same area with the co-infection. So you may get sometimes co-infection with dengue and chikungunya also. I had one patient who had dengue also and chikungunya. So what are the differentiating? Fever is very high in all the three. Rash is more common in Zika, then chikungunya, and then dengue. Conjunctivitis is in Zika. Arthralgia is more common in chikungunya. Then myalgia is more common in dengue. Headache is more common. Retroorbital pain is more common in dengue. Lymphadenopathy is another feature which is common in Zika and chikungunya. Then hemorrhagic and shock are more common in dengue. This is important. Leukopenia, you can see in a dengue, but lymphopenia, it is common in chikungunya. Thrombocytopenia is usually not seen in Zika, but common in dengue and maybe seen in chikungunya. CRP is elevated, not in dengue, but in chikungunya and Zika infection. So, lab diagnosis, lymphopenia, hypocalcemia is common. CRP, you may get increase in CRP, sometimes increase in creatinine, hepatic enzyme, and CPK. Specific test viral isolation. In first 5 days, you can do the chikungunya PCR. So 100% sensitivity, 98% specificity. So you can do in first 5 days. Most of the time, it is a clinical diagnosis. And usually self-limiting disease, so may not require investigation. Then serological test, you can do IgM, which is the sensitivity and specificity is very good. So 5 days to 3 months, you can do IgM and IgG after 2 weeks. Then other tests are available, but specificity of serological test is not high because of cross reactivity with some chick virus with some other arbovirus. Still, IgM for chikungunya is very sensitive and specific. So, but even after third, fourth day, they say that you can do ELISA IgM, not CAR test, ELISA IgM. Temporal sequence, you can see that in this graph, you can see viremia first 5 to 7 days, fever for 3 to 5 days, sometimes 10 days. You get arthralgia and sometimes rarely chronic arthralgia, myalgia, skin rash after 3 to 4 days. PCR detected for first 5 days. After 5 days, you can get IgM positive. So, WHO classification, probable case, patient meeting the clinical criteria. What are the criteria? Acute onset fever, severe arthralgia or arthritis, not explained by any medical condition. It is probable case, possible case, patient meeting both clinical and epidemiological. There are epidemiological criteria, the residing, having some visited to the epidemic area in last 50 days. And confirmed case is a laboratory criteria irrespective of epidemiology or clinical criteria. The positive PCR, or viral isolation, or IgM positive, or for rise IgG. So what is the treatment? No specific treatment is available at present. So what is the best thing is the good hydration and acetaminophen or paracetamol is used, and that is the safe. Hospitalization is required sometimes because of vomiting or high grade fever, especially in the infants or older adults or immunocompromised patient. Antibiotic analgesics based in the paracetamol NSAIDs only when dengue is ruled out. So you can use the ibuprofen, but you have to rule out the dengue associated because it may coexist. And co-infection with dengue and chikungunya virus can occur. So acute dengue infection needs to be excluded if diagnosis chikungunya infection is confirmed. Ibuprofen, naproxen can be used, but nothing has been proved superior. So best way to use the paracetamol or sometimes ibuprofen. Opiate analgesics rarely used in the pediatric age group. Steroids, the role is controversial. And during viremia, you may not use steroids, but adults they use steroids. I think Vijay can throw the light on this. Then rash disappears spontaneously. Post acute stage, again you can continue paracetamol or NSAIDs if needed. Systemic glucocorticoids, sometimes they are used. Then pregabalin and gabapentin. Chronic disease may require help of a rheumatologist. Disease modifying agents can be used. So for prevention, now there are two vaccines which are available, not in India but in US. One is the VLA 1553, which is live attenuated vaccine, single dose vaccine, and another is VLP, virus-like particle vaccine. This is phase 3 trial, but at present in India, no vaccine is available. So how to protect yourself from chikungunya? Maybe the viral vector control and personal protection to prevent the mosquito bites. And here, Sridhar has already told about this genetic and biological control about the mosquitoes. So this is in brief about chikungunya, chronic symptoms chikungunya. Thank you. Thank you.
Thank you so much. Excellent talk as usual. Any question? Yeah, everybody has understood the topics and then.
PCR disappeared after not go after 5 days. What?
PCR recommended is first 5 days, but some patients up to 15 days also can get PCR also. Sometimes why may remove for a long time.
How long does the hypopigmentation of
It is in the 1 month. After 1 month.
Oh.
So to निकाल
So we are saying the baby is being probably final one in Mumbai. As you know, the solar in repetitions, right? So people used to initially think only repetition because it rash and some pigmentation was coming up. There are no sophisticated instead of this. So
ये करना है रे इंट्रोडक्शन इंट्रोडक्शन
So different language, but As you said, this chikungunya usually fever in children disappears after 3 days. Rickettsia fever doesn't disappear. So, 2006, I photograph. That time, this photograph from the 2006 only. Most of the photograph. And because this was some different key manifestation. If you see a rash of a rickettsia, it is a macular or papular, I think, on palms and toes. Here it doesn't come. Here is the flushing is very common. Dengue flushing is common. But as you say, initially everybody was rash and fever. The doctors again tell us. But they usually used to settle within 2 3 days. And at that time, we used to see 200, 300 COVID patients per day or for 1 month because going on. All the hospitals were full. As a joke, they said they have earned like anything. They have made a chicken gunia manzil. They have gunia manzil like there.
Right? Very repeatedly. It was spreading mostly the children. Only the infants were getting infected. Most especially the people who have their many situations where children are fasted.
So having known about the monsoon illnesses, if there is the rainy day, as the food says, when life goes on rainy day, play in the puddle. But every time it cannot be the same. This puddle can easily turn into puzzle when our child decides to misbehave. Especially when they can go in shock or respiratory failure or inflammatory coagulopathy or cytokine storm. So everyone please pull your socks, keep your antennas up and let us learn about the signals for these storms so that we can face the critical illnesses during in this monsoon season. So I welcome our first panelist for this, Dr. Atul Kulkarni sir. Sir has vast knowledge in infectious diseases, especially in chikungunya, rickettsia, and I'm sure the inputs are going to be very good for this session. Our next panelist is Dr. Vijay Vishwanathan. He is a pediatric rheumatologist from Jupiter Hospital, Thane and Apollo Children's at Navi Mumbai. He is our go-to person when we are stuck somewhere when the child doesn't respond to our treatment as we want. And also thank you for accepting to deliver your words of wisdom which are going to be there after this panel. Our next panelist is Dr. Amol Jayabhai. He is a pediatric intensivist, infection disease specialist attached at SRCC Hospital, Jupiter Hospital, Thane and Surya Hospital, Chembur. And next we have young brigade of intensivists from Navi Mumbai, Dr. Narjan Mishra and Dr. Priti Sathe. Narjan Mishra is from Apollo Hospitals, Lapur, and Priti is from KVA, Navi Mumbai. I think we have the panel of experts and we are going to have wonderful insights from them. And to conduct this session, we have our moderator, Dr. Parmanand sir. Sir is head of the intensive care at Jupiter Hospital, Thane. He is known for his passionate intensive care. Thank you, sir, for being here.
Thank you for those comments, sir. So we have an excellent session since morning about the daily and the other things. So most of the patients, hopefully we have to have a zero mortality. That's our aim. So it doesn't happen always. There are few things, maybe less than 1% do misbehave. And constantly we got some I remember that one patients like that. So just to have a different thought process of what we learned in the morning, the lecture about the daily. If the case based in this unit panel, and luckily Vijay is there, he was there doing that managing the patient, so he can give this insight. So the so this was slide prepared by my daughter yesterday morning. Like in the monsoon, usually we get more infections because of increased immunity, contaminated water, or vector breeding grounds. And most of us we get the
all the diseases, either it is waterborne or airborne, waterborne, cholera, jaundice, the malaria, dengue, or any other one. So let's go through the cases and we'll discuss. We like to have inputs from the audience also. So the 12-year-old female child came with complaints of fevers in 4 days, nausea, reduced oral intake 60 days, reduced urine output, generalized weakness, giddiness, and abdominal pain, and they tried to the admission. Was investigated and started on IV fluids in the private and child, however, were continuing to worsening warning signs, abdominal pain, giddiness, and no improvement. On examination, heart rate was 146 per minute, respirator 45, stroke of 95, pneumonia, periodical system, BP, blood pressure 118 by 55. On examination, just liver was palpable, she was conscious, oriented, no focal deficit to starting. So, Priti, how do you interpret with this initial phase of this illness? What we are seeing nowadays in this day?
So, sir, this child has presented to us around day 4 of illness with the nausea, vomiting, the typical warning sign that we see in dengue, vomiting, abdominal pain, along with the reduced urine output, which is concerning. And on examination, if I follow the ABCD approach, the airway is open, she's slightly tachypneic, she's tachycardic, with feeble pulses and a normal breathing. So the physiological diagnosis currently will be more in favor of a compensated shock. So for me, this compensated shock first likely diagnosis would be secondary to dengue. But I'll also like to keep the other monsoon illnesses like malaria and plague also at the back of the mind because they can also present it.
So he heard that the worsening signs, there's warning signs, worsening abdominal disease, and unless for this season, the dengue will be definitely, and here tachycardia, tachypnea, that suggests that the leaking and blood pressure was normal. That is signified that she was like kind of in the shock with a compensation and blood pressure is maintained. So that was we thought of. It's a suspected dengue, compensated shock with our classification, which should have a dengue warning signs. So we as an intern look like a shock or no, like a dengue warning signs or generalized situation. So this question in the mind, John, how to manage in this situation, like a dengue fluid, how much fluids. First question was fluids, blood, what, and any other investigation to know the severity of the illness.
So, each child presented with us with compensated shock. So, rapid early recognition is very important. And second thing is that child is having, you see in the BP, 118 by 54. So, diastolic blood pressure is on lower side and pulses are fever. So, here I would like to give some bolus to the child to come up with 90% of cases crystallize work better, and only 10 to 5 to 10% of cases we require chloride if it is not coming with the crystal. So at least for if it is dengue, so we should maintain the strategy that we should balance the fluid, urine output, and blood pressure, hematocrit. All these things need to be taken into consideration. So at least as per WHO guideline, we can go with 7 to 10 ml per kg bolus and see the response. If after giving a bolus also the response is not coming, that means it could be after 1 or 2 boluses. Then third bolus, second or third bolus, we could consider for coli, like the extra. And if it is available, I will prefer alcohol. That is 5% alcohol if patient is affording. So that need to be given over 30 minutes to 1 hour. If you are giving for 30 minutes, you can go with a small bolus also. 5 ml per kg. If you want to give it for 1 hour, 10 ml per kg. Regarding blood products, we need to monitor hematocrit. So we have divided hematocrit in 3 categories: mild, moderate, and severe decrease. So first is in between. Suppose decrease in hematocrit is high. Suppose decrease in hematocrit is 5%, 10%, and 20%. If there is a significant decrease in hematocrit, and if there is a suspected dengue hemorrhagic fever with dengue shock, then we should be very aware about the blood loss. and the bleeding from lungs, or there are multiple petechiae somewhere, or there is loss of blood, we sudden decrease in hematocrit. So the choice is whole blood transfusion, but we rarely get whole blood in our blood bank. And if there is an increased fluid overload, if child comes in a very decompensated phase, so we can go directly to PRBC. So we could give a PRBC 5 ml per kg slowly in these kind of children.
Yeah, that's what we learn in the morning about the fluids. We don't want to debate too much or discuss too much about the fluids. Only thing what we are saying is if there's a drop of the hematocrit, which is significant. When you are giving fluids, fine, you expect that hematocrit should drop. But if it's dropped significantly and there's a tachycardia, think of internal bleeding. And there is a role of giving blood products in that situation. So we expect that there is a deep fluid, and with the 13 it may 11, or if it's the hemoglobin drop to 5, so it is not because of the fluid overload or if we are giving too much of fluid. There can be an internal bleed and it may not be obvious. And intestinal bleed can be like you may pick up little later on. Maybe later on you will start a malina. So drop in hemoglobin, and which is not expected to drop too much, then you start thinking of the internal bleeding, and then there is definitely a role of blood product. Otherwise, the fluid you give, monitor the hematocrit drop, we see the sensorium, monitor the urine count, and that's what optimally fill, no lower or no under. That's what we have learned in the morning. So this was the investigation. So the hemoglobin to start with, the 50 platelets were 1,50,000, and the CRP was done at 59.7. And I will later on see why the significance of CRP can be there in dengue. And the repeat investigation showed 17, platelet was 16, the came to Jupiter. NS1 was positive, empty antigen was negative. So, how do you interpret these reports and how to go ahead with further?
Okay, just before that, just about the few lines about the fluid. Because we had dengue since 1998 actually. First case was with me only. And 2000, from 2004, what I am following the strategy is giving one bolus, and after that coming down to the fluid to 2 to 3 ml per kg. These guidelines came to 2014, but I am following from the 2002 that I am doing the same practice. A rapid coming down with the fluids, because if you fluid overload is the cause of mortality, as Dr. Fernando also mentioned. And another thing, I was using Dexan 40 initial 5, 6 years, but now I am using albumin, especially with the infants which are less than 1 year. In those babies, they have very small this capacity or the third space capacity, and small amount of fluid can cause the respiratory distress, lung fullness, then hypoxia, everything can occur. So in this, I use the albumin half and half. Means suppose 3 ml we are giving to 1.5 ml albumin and 1.5 ml normal solution, and that reduces the amount of fluid giving and third space loss also.
That's true. What we have seen, the severity of the dengue is less than 1 year and move to the adolescent age. So usually in between they are not that critical what our observation is. And mortality is very nice in infantile dengue and an adolescent. These are the two subsets where usually when they come we are alert. Like they can misbehave. So this and the fluid management definitely, because why we are worried about fluid, too much of fluid in the infant, ascites, it will lead to the again breathing difficulty and all those things we don't want that. And definitely what we calculate, what Sir has said about volume, we can look at what is volume retained. So we calculate the daily fluid input and output, and it is crossing around 15 to 20% more, then you are alarmed that there is a like it is leaking too much and it is going to cause more complicated. Too much of fluid overload definitely is increasing the mortality. You try to get rid of it. That's what Sir said about you fluoxetine. And this leakage phase data is for 24 48 hours. And then you give that and get rid of that fluid. So you may give prolites at that time. Only thing what we do is we don't give bolus. We try to give an infusion and slowly, so the hemodynamics are not altered too much, and monitor the urine count. And mind way when you're giving diuretic, what Sir said, and you may have a good urine output, but not at the cost of your perfusion. So if you have facility, you monitor the lactates, if the urine output is increasing, so you are happy that the urine is good, but maybe an intravascular depletion and that is causing tissue perfusion which is getting affected and the lactates are rising. And in the daily, when depending cause of lactate high or whether it's a perfusion which is caused with lactate high, it's very tricky. So it is very cautious when you're using a diuretic in a patient daily. So optimally, if the lactates are not rising, I'm happy, go ahead and give me diuretics. So these,
So the investigation what we are seeing here on admission, hematocrit has increased 17.9. It was previously sorry, hemoglobin was 15.9, then it came to 17.9. And platelets are also dropped down rapidly in these 2 days. And OTPT they are very high. SUT is 5,000. So this is dengue. I would say this is severe dengue.
yeah, this is severe dengue.
Severe dengue.
Yeah, and you may expect the complications.
May expect the complication and inflammatory biomarkers may be high in these cases.
That's what I said about the CRP.
CRP and
Generally, we don't want to, but some of the time in early phases of illness, if you do it, they may say that it can have an inflammatory component which is there with the dengue. So that's what I take it as a CRP with the initial phase if it's negative, and if it's positive, I take it as a inflammatory marker indirectly. CT brain was done for lateral because just put it here and why you got a latency. So this academic PSC was started on oxygen, started on fluids, then colloids, platelet transfusion, vitamin K, then there was a changing sensory and intermittent irritability. And this happened, I think this patient came walking at around maybe at 12 o'clock or 1 o'clock, and in the night again I went just for a round. I saw there was a waxing and waning of sensorium intermittent. So is it worsening of shock, worsening of encephalopathy, hepatic, or there is a CNS involvement because of dengue. So these are the thought process which came to mind. So we gave a diagnosis of a dengue shock syndrome. So it is important the amount. So this little bit different than what we usually see in a dengue management. Is it important to understand the pathophysiology of dengue, or does it help us to manage the dengue better than only just a protocol?
Yeah, it's important to know the pathology of pathophysiology of a dengue fever because by that we will also come to know the patient is in which state and how to go ahead, like how aggressive to treat or not. So whenever you get a mosquito bite because of the dengue mosquito, it will first it will first attach to the dendritic cells of the skin, and from there it will get targeted to the multiple lymph nodes where it will activate or more recruits more monocytes and macrophages, and that will lead to create more secretion of more protein like interleukin 2, 4, 6, TNF alpha, then other tumor necrosis factor, and that can lead to a problem that can cause increased vascular permeability, leading to a fluid going outside like the pleural and peritoneal cavity, and at the same time the escape of platelets will also start causing the thrombocytopenia.
So if you understand the pathophysiology of initial phase, the dengue, what we look at in the 2 3 the classical dengue, there will be viremia, then there is the after 4th to 5th day or something, there can be a leak, and then there is a reabsorption. But some of them don't follow this protocol. Some they just initial phase in first 2 to 3 days only they are severe, they are fine, and suddenly they will shock bleeding and something. This is different. The second phase of illness may be after the phase which comes on 4th day, 5th day, and then it is deteriorating, that is different. And then in the reabsorptive phase, it is different. The first phase when it is there, and if suppose they have thrombocytopenia, liver rearrangement, it may not be just a dengue shock syndrome, and there is something different pathophysiology. That's why it can be. And now, which virus initially you have the second attack, what sir said, it can be serious. So when we get first infection, you will get an antibody formation. But if the other second virus which comes up and it is not of the same, it may be type 2 or a type 3. So antibodies will be produced. But these antibodies are not going to be protected, and this antibody dependent enhancement can kill or it can cause a problem or the injury. And there we get altered sensorium, bleeding, and all those things. If first is the viremic phase, the injury which stimulate the infection and they start. Second phase is the antibody dependent injury that usually the antigen antibody takes time, maybe a fifth, sixth day the patient is worsening. It is an antibody dependent. And third phase, when you have later on, if it is developing, then it is because of the reabsorptive phase with myocardial dysfunction. So, which phase of illness the dengue is worsening, you will get the answer. So, if I am on the first day, 2, 3 days, I know it is not antibody dependent enhancement which is causing a problem. It can be an acute storm. Like a storm, we don't have like a prepare it, and suddenly there is a problem. So, this pathophysiological treatment change. And why? And that's what we will evolve this phase and we'll see what the thought process is. So if the first phase, the star, the treatment differ. In the second phase, the antibody dependent, then the treatment differs. That's what we learned, and thanks to Vijay for helping us to understand this. Vijay, reports come and like in this situation, when there's a thrombocytopenia, liver involvement, where is Vijay?
Finally, I got the mic. Full battery. So let's assume for practical purposes, most of them will be dengue unless proven otherwise. So you have either an MS1 positive who walks into the hospital, or he may be an IgM positive. So rule number one, document the etiology, which is dengue. The minute I start seeing this child or I start hearing the story from the residents, a child who was perfectly fine starts having high grade fever and then starts having low or decreasing sensorium, there is an evidence of organ involvement now in the form of worsening liver functions and a worsening CNS dysfunction. I always like to do a CRP and an ESR even without knowing what I'm dealing with because I can sum it up in the last 10 minutes if you guys have time. A CRP negative in a dengue doesn't mean he's not going to end up with trouble later on. Having said that, like Dr. Paramanan said, if the CRP is high in a dengue with this kind of a scenario, I am more concerned about not just about a brewing cytokine storm or an HLH or a macrophage activation. I'm in fact worried that whereas this CRP is also a marker of if I immunosuppress this child a bit too much, am I risking a secondary bacterial infection which could be counterproductive? But just to sum up this slide, this is a child whose counts have dropped, platelets have dropped, LFTs are getting deranged, and we just touched upon albumin in the morning briefly, whether to give albumin or not. If you think of albumin in a short history, we all know Dr. Ambedkar's teaching. Chronic liver disease, low albumin. Acute liver disease with low albumin tells me there is severe inflammation which is suppressing the production of albumin. So all put together, this is a sick child with at least two organ involvement, if not a third that's setting in. Definitely has marrow suppression, and you are in that 4 to 6 days window period, which is the most critical. And I am seriously thinking if this child is heading towards a potential cytokine storm or a macrophage activation of sorts. So what challenges we had now? We had reduced syndrome molecular involvement, hyperferritinemia. It was a level of 165, right? Coagulopathy. We have encephalopathy. And the encephalopathy is the shock, liver failure, or primary involvement. Eliminated markers of inflammation. So hepatic failure is causing and AKI is developing, urine is dropping, creatinine, and we have these challenges in around in a day. NS12 positive still on the fifth day of illness. So impression we thought of it's a dengue with cytokine scar. And is it HLH? It is macrophage activation. Really, yes, because 165 is not the acute phase innocent bystander. While I like Dr. Fernando's talk a lot because it actually reminded me that I used to be a pediatrician with fluids. I
think I take a slight objection to one sentence, go to ferritin. My interpretation is please go ferritin, whether to act or not on that ferritin depends on your routine monitoring and clinical assessment. This child is clinically worsening in front of your eyes, has encephalopathy, has hepatitis, has now a renal involvement, more than 3 organ involvement, and 1,65,000. So there are enough papers to say more than 10,000 ferritin is HLH unless proven otherwise. You may think about possible etiology, but this is a child who needs definite aggressive management. This is macrophage activation in a case of dengue. So how to proceed? Management of air breathing circulation will intubate the child. Will is according to the protocol what we do. Now the main question, that's what where usually 99% of our patients get better. This air breathing, oxygen, fluids, and most of it. This is the some subset of patients, not always, where we challenge, big challenge. And that is where there is a macrophage activation, stop, and the other organ involvement, and where the real intensive come into picture. So the airway, we intubated the child, sensorium was deteriorating, and investigation per se and fluid resuscitation were conducted. So what usually we look at this infection, when we're talking about treatment, infection, the source control and endocrine plaque and toxin removal is required with medicine or because of some BCRRT. Immune modulation, dysregulation. This is immune dysregulation, where you may require some medication which is required. And third is an organ damage, where you want to give fluids, you want to remove some fluids. So there is this phase of illness which come up to the some patient with dengue. So the now dengue steroids, which what dose? At the same time, because I will cover this in the last 10 minutes, but in this case, because this child has a rising CRP, I will definitely send a blood culture, cover with the adequate antibiotic, and 1,65,000 treat this child as an HLH while activating my colleagues on the far right to start mobilizing. So there are two things. One is what is causing the wholeness, possibly cytokine storm. What do I do about the storm? I would try to inhibit by using immunomodulation while I get enough chance to this child to get rid of the cytokines by using alternate methods which the intensive care people would possibly consider a flex or a CRRT, or there are two ways: block the cytokines and remove the ones which are creating trouble. Be aggressive. Which steroid to get, I'll discuss it later on, but today the drug of choice is methyl prednisolone, no 2 mg or 10 mg. This is straight either way for 13 grams per kg. Up to IgG, the IgG we have used in medicine. But the first drug of choice is steroids. IgG may not have the volume which we have, and again it will not be tolerated well. So it is very dicey in such situation. So usually we try to avoid. Now, anaconda you want to talk right now or? Yeah, so it's an IL-1 blocker which usually some of this immune modulation which can be used. You want to just brief it? Yeah. So we know that culprit in dengue cytokines from the predominant cytokine which is getting aggravated with the IL-1 family or IL-18, and anakinra is one drug. If you want to take home one message from my side is wherever feasible, whenever feasible, if faced to a crisis like this situation, get anakinra easily handy, because unless you try it, you will never be able to use it or convince the pharmacy to stop it. It seems to be a great drug provided you know when to use it, how to use it, and how soon to use it. It's not really available. So unless I show you this was a living example where we did anakinra. Definitely some case reports which has come up now with the use of anakinra with other supportive therapy, and they have found to be, and how it works that we will explain. Now once we have the medication part of the stop, the organ failure, where John pretty we come. So CRLT is led IHD. These are not with all patients. We are just looking at how it can help in some of the patients and which modality.
So basically, if the patient presented in the cytokine storm, and we also discussed that he also has it having AKI and as well as multi-system involvement. So better would be the CRRT modality over here. And regarding the cytokine storm, we can use some filter in CRRT. So that will help to remove the cytokines which are dangerous to the patient going into bad phase. So we can use with the CRRT. So my modality will be over here is CRRT. And
if there is you can have slow level infusion or HD depending upon the hemodynamics. If the hemodynamics are unstable and you have to remove the fluid and give fluid, the CRT with the modality and it removes the cytokine also and be able to manage the fluid better in this situation. Right. If you know that.
Yeah, so as you said, this hemodialysis will require stable schedules that can also lead to a dialysis disequilibrium syndrome when a patient is already having hepatic encephalopathy. Now, to CRRT in an unstable child, we will face fluid overload in the next 24 48 hours from this patient. A dental fluid removal, ultrafiltration, removal of the cytokines, everything will be better.
More controlled fluid management can be there with CRRT as compared to the other modality. If not, the center is not equipped with this. This modality was plasma dialysis. So if you don't, that is works as a very wonderful, the renal replacement therapy on those resources, and it is not possible to be have done, and they do very well with the peripheral dialysis also. So the problem with the IH, the dialysis is the amount of fluid and extracorporeal circuit can be high. And you are volume depleted, so suddenly they can crash. That's why the modality of IHD versus the CRIT is slow. They will do less volume and you control volume over a period of time. Role of plasmapheresis, you want to, and I will touch upon that. Role of CRIT, what we describe is role of removing the inflammatory cytokines, direction of electrolytes, acid issues, current overload syndromes, and these are the modalities which helps in CRRT. Yeah.
plasma is one of the modality. So steroid, IVIG, and plasma they go hand in hand. So if this patient is not responding, we feel that the response is not coming, we can go with the plasma Daily one cycle we can go, at least 3 to 4 cycles, and watch for how is the improvement. So here we replace the plasma in which the cytokines are there, antibodies are there. Suppose first response is cytokine storm and then antibody mediated the things are there. So we can do that. If it's not responding to IVIG and steroids, so we can go with the plasma players.
So what here, when we talk about the physiological risk management, we said about the antibody dependent enhancement which is causing an injury. So this modality of treatment, what we are doing with the plasmapheresis is we are removing these antibodies from the circuit. And then we put and replace it with the normal plasma. This definitely do wonders. As luckily at this time, simultaneously one patient again came and we didn't do CRT and we just went ahead and we did the plasmapheresis. It was encephalopathic and IgM positive with NS1 negative. So it was NS1 negative, IgM positive, altered sensorium, encephalopathy. We did, and within 2-3 years, his bleeding profile derailments are improved and suddenly fine. And then we went to body and later on and discontinued, and she's absolutely fine, normal. So was came with the status separate. So the modality with plasmapheresis with the and what I look at as an antigen positive, still on that's a 5-day with high CRP, it's a cytokine storm. Here we suppress the storm, remove the cytokines, and it is on a day 5. Then there can be some antibodies, so which is causing double damage to the child. So remove the cytokine and remove the antibodies with plasmapheresis and continue to remove the cytokines with your CRRT. And when you are talking of coming on the day 5 of illness with altered sensorium and bleeding profile range, day 7 of illness, it is more of an antibody dependent enhancement. So here the plasma therapy definitely can help and give replacing the plasma. Just giving plasma may not help. So that is the thought process which Raisa said, whether the physiological based management change our thinking of dengue. It is not for all. It for some subset of patients definitely make a sense. So there are certain the papers also therapeutic plasma exchange along with the other therapy has definitely shown the response in a dengue shock syndrome. So what the Juma was talking about is cytosol. Here the initial phase when the storm, here you remove these cytokines and do a CRRT. So then this cytosol is used.
Cytosol basically helps in removing interleukin, cytokines, leukotrienes and all, and that helps to remove it proper, very good manner. So we can deal with the cytokine storm. But you have discussed with one drug, anakinra. Anakinra is also very useful in that case, and that is specifically made for ICU, I think so. So in a critical patient. So like other monoclonal antibodies, have their own side effects, but anakinra is very safe in ICUs.
Yeah, same thing, you see the cytokines which are this concept came up when we looked at the COVID. The COVID, they used this cytosol in initial thing with the storm. They remove and they prevent endothelial damage. But what are the things which they do? They remove the pro and anti-inflammatory. So this you have to be very careful when you are using this cytosol. It is going to be a good and bad both you are removing. If you remove too much of the antibody, there can be a late infections also. The duration of the cytosol we use for just few hours, maybe 6 hours or 8 hours, so that your cytokines are removed till you get Vijay for anakinra. So this till that time you definitely because at that time you are removing. So this system. Then what you're going to do is you're going to suppress what is going to get produced. And that where the anakinra may continue to help for prolonged period of time. And indirect marker, what we looked at is the ferritin. So if the ferritin is rising too much, so that is one of the indications that you may have a storm going on. Right now, just removing this initially at that time has just suppressed it. But if you stop there and it is going to get produced, it may again continue to damage. So we continue, we gave the plasmapheresis, CRRT continued, we gave the cytosol, methylprednisolone was given, and the anakinra was asked for. Look at this, the ferritin was 1,65,000. With one, the cytosol has completed, it has come down to 54,000, and we continue the plasmapheresis, the ferritin has come down significantly. And by that time, we added the anakinra, and the anakinra was added, and you see this, the ferritin has come down, and over a period of time, the markers also has improved, the liver enzymes also improved, the platelet also improved over a period of time. So the CRRT continued, cytosol initially with without ultrafiltration. We switched to plasmapheresis with CRRT. We added anakinra, and then we developed the hyper. Then in the recovery, she developed hypertensive encephalopathy, which again tackled with the medication, and then she improved over a period of time. So there was no severe setback, and she was undergone the physiotherapy, other things, and improved and sent to. She just came follow up in the last week or more, and she's doing absolutely neurologically and everything is fine. So this is some subspecialty, this is just thought process, what I wanted to give it to everyone. So this can be a thought process. When you look at the dengue, look at the pathophysiology, what is happening, and choose the drug accordingly, not to all patients, but to some certain of patients, with definitely a friends like Vijay and other together, we can do one. And we go to the next, the fever is 5 days, cough is 5 days, vomiting and reduced oral intake, no rash, disturb abdominal pain, burning ulceration, no history of family history of any similar injury. He came from San Diego and he is a patient, he is a US citizen. With vast history of occupational repair, lawless seniors and he's an artist, autism spectrum disorder. On examination, he had heartbeat of 90, respiratory of 38, SpO2 87, O2, and then the blood pressure was normal. What can you think of on this situation? Hereditary was bilateral, there was a reputation.
So this child has come with a fever of 5 days with respiratory symptoms, upper respiratory tract. But along with that, I can see that along with that, he has respiratory distress in the form of retractions, tachypnea, and also the saturation we see are much lower on oxygen support. So this is possibly a case of respiratory distress, secondary to a parenchymal disease, probably a pneumonia or an evolving ARDS, so that things we have to keep in mind.
So what investigations you ask for?
So basically, if I'm in intensively such a child come in my ICU, at first I will go with a gas. So I will know about the metabolic picture of the child. Second thing I would go with how is the heart basically. So child is having underlying heart disease. So second thing would be that one. And third thing would be blood investigation, CBC, electro function.
CRP was time, the rest of the investigation of time, and that was the blood gas which we ran and those are the excels.
So blood gas over here is ELT is okay, or the PCO2 suggests your child is statically. Bicarb is 18.8, somewhat dehydrated, and PO2 is very low as compared to what you are giving. That suggests you have significant lung involvement because of low respiratory tract.
So purpose was same, and he first stop on marijuana.
So
So each patient you will ask for adenovirus. So basically adenovirus generally we don't do routinely, but there are certain these parameters where like the symptoms are unusual, patient is rapidly progressive, having bilateral crepitation or bilateral involvement, bilateral pneumonia, or patient is having some comorbidities, or the patient is immunosuppressed, like transplantation, post-transplant, or solid organ transplant an unusual presentation with ARDS, we have to do a throat swab or SOS bar with the patient who will be okay to get the diagnosis. Basically, what is the turnover time of the adenovirus PCR? So adenovirus PCR is not commonly done, but if you do, it can be done over a period of 6 to 8 hours total time. But the runtime at different labs will be different, so it will take at least 24 to 48 hours to come to know if it's positive. Sensitivity and specificity is more than 95% or 100%. And yeah, and the cost of the adenovirus ranges from that to that, but it is between 3 to 8 hours.
So we, as an intensive care, so because now the PO2s are low, so how should we manage this?
Well, first of all, suppose child is in ER, we'll start with oxygen because basically there is hypoxia. But if child is in distress, I will go with a more advanced form of ventilation. Like I can go with the CPAP or intubation. What is wrong?
CPAP or intubation, like in today's modality, you can give the non-invasive way on the HFNC. We started on the HFNC, and the HFNC on 90% FiO2, that is the blood gas.
So low is 60 liter, FiO2 is 90. So blood gas, pH is 7.34, PCO2 is 45, PO2 is okay. So if the child is not in distress, not from tachycardia, or if they little bit settled down as compared to earlier, which I seen in here, then I will continue this modality HFNC if everything is okay.
And then later on, we can titrating the flow and the oxygen, which resulted. So people persistent RDS, what can be the cause or what thought process goes in the mind of the intensive if it is not improving?
So basically,
what to add, you can add.
So on hypertension, the fever is persisting, the distress is persisting. The distress persisting in spite of proper operating support is concerning as well. Maybe we are not giving adequate pressure support to the child, that is causing the distress. Second, they are not covering the appropriate antibiotics and antivirals for which the organism must be sensible. There is another possibility wherein the distress and the fever might be present.
So basically, the child is going to deteriorate, going in deteriorating phase and increasing requirement of the support. So it is a suggest of involvement of consumer. Basically, they are expected to go into the
Worsening of the primary disease, which will be support, and then you go on increasing. You may not have to take an X-ray, but only on the increasing the requirement of support of oxygen or the support, we know that the lung parenchyma or there is something else which is happening. Either it's a secondary infection if it's a bacteria, or the cardiac dysfunction or the shock. These are the possibility when the distress worsens on the regular support. Role of antiviral in these situations, in this scenario, he has an adenovirus. Whether you want to give antiviral, adeno usually you don't prefer to. So whether you really want to give an adenovirus, you have the antiviral.
So generally the antivirus for adenovirus is not pseudovirus is recommended.
But I use fluid, I don't have.
Yeah. So fluid doesn't work on the adenovirus. Second thing, pseudovirus is mainly used and proven in only immunocompromised patients where the post BMT they are where their T cells are very low and they will have very severe infection. At that time we will do, but now recent of late between like after 2016-17, increasing there are anecdotal reports where you can use in an immunocompetent child, but there are not recommendations. These are used on case to case basis where you find that if you have very high adenovirus load in the blood, that can cause more damage. And to prevent that, you can use sulfapyric for that, which basically act on a, it is a nucleotide analog which basically decreases the replication of the adenovirus and it will decrease the viral load. Adenovirus, sorry, sulfapyric you have to give, there are two different regimens. One you can give once in a week by 5 milligram per kg per dose, and second is 1 milligram per kg per dose alternate day. The one preferably people use one to avoid the nephrotoxicity. But if your patient is severe, you can go directly to the 500 per kg for dose once in a week because the cost of the drug is very high and it's but there is a certain protocol you have to use because of it causes nephrotoxicity and it will also suppress the bone marrow. So you use hyperhydration like 10 to 20 ml per kg before starting sulfapyric, then during sulfapyric, and then maintenance fluid after sulfapyric. But to reduce the toxicity of that nephrotoxicity, you have to use probenacids. So normal dose is like 25 to 40 milligram per kg earlier, and then you have to give 3 to 6 hours later and 9 hours later. So to avoid the necrotoxicity.
That's what when talks different toxicity and other before if it's administered with other drugs, there can be a increase in our toxicity. That's what precaution. That's the reason we don't prefer to use the sulfapyric as treatment. Then usually with adenovirus with a competent child, usually they don't require. They may have prolonged fever and other things, but in certain situation, that comes to mind. Should I do a basic immunologic workup in the patients with immunodeficiency workup in an improved adenovirus with the severe form? Reality is now this is a lung which is causing the ARDS. Should I do a immunodeficiency workup at this juncture?
No. Yes.
And his actually अभी हम सुनते हैं we had said this and his IgG has come low. How should I interpret here? And well, LSSL also sent, and whether I should send or if it's sent, how I can interpret.
So here the IgG level is very low, normally recommended is above 600.
Yeah, but
700.
During any acute infection, these studies will have their compounding effect. I don't know whether syrup will cause any harm to this patient, even if it is not immunocompromised. So my take, if it's a dying child and serious child, I'll go for syrup at a later date because this can have a compounding. Secondly, not that with acute illness you cannot do immunodeficiency workup, but you'll have to look at a different markers. So there are
neem cells which can be taken from the blood as well as from bone marrow. And neem cell can give better, not the immunoglobulin levels. These are not the markers which can be looked at. If you are really desperate to look at it, look at the neem cells which don't change during acute infection. Rather, these markers, get this kind of number, forget, go ahead and give the syrup and look at the numbers again after 3 months.
Yeah, that's once you recover completely. The immunodeficiency definitely worked up after 3 months. When you look at that, yeah.
I want to make one point over here, whether it is influenza, whether it is adeno, or whether it is something else in the viral infection. The child is having underlying cardiac situation, and we know in the literature also, in our experience also, those are underlying chronic condition. They presented with such a kind of scenarios.
Yeah, so already definitely with this any infection can have severity which is more. Any role of IgG? If you have proven, suppose now IgG levels are low, in this situation, wouldn't you want to give us the yes.
Actually, recommendations are primary immunodeficiency patients if they get viral infection, one should give IVIG. There are few papers from China which has they have mentioned that we can use adenoviral IVIG 2 gram per kg, one gram for one day and second gram for second day. That can be used in a severe adenoviral infection in immunocompetent child. The papers are there, and I had a few patients last 2 years back who had a big outbreak of adenoviral infection. That was on ventilator for 20 days, and the entire left lung was totally consolidated. Right lung half also consolidated, and high blood fever he was not responding. In that situation, I have used immunoglobulin. 2, 3 patients I have used. Similar, sick, very sick patients, not a routine patient, not other patient don't require. And supporting few papers are there. I engage.
He had a quick walk test.
Because tenofovir was first thing was not available at our place. That was one thing, and also cost is high, and also nephrotoxicity is another problem in facility.
Yeah, Amol, one.
So basically, in immunocompetent child, the first treatment of choice, if at all there is an infection, you can use IVIG first, and then go for the seroconversion if the child is not improving. The basic idea was doing IVA immunoglobulin to see that already the child was bone morbid having the this thing. If you see the CD3 and CD19, both are suppressed too much. Even sometimes infection cause rise in this response, but in a severe infection, he is having very low level. So there is some component of the immunodeficiency in the background. So that could be the idea. Like if the child is, we were considering initially the child as an immunocompetent and why to go for a pseudocovir, but these low levels of IgG, because if you see the infection, the IgG levels go high. They will not decrease. So even in a decreased level, it will help us to guide or teach or to give medicines as early as possible and go aggressively.
So lot of ARDS and we can like an release with fever on it. The HFLC we just continue the therapy. But I will intensity, it doesn't let him go what we think of. I was thinking he maybe is maintaining well right now, supportive oxygenation is maintaining, trying to be on one side of the way. And there are always surprises in the intention. Sudden heart rate of 220, peripheral pulses weak, blood pressure come down, respiratory distress, sudden oxygen requirement went up. Now, what can be a thought process or what how we should have proceed? Maintaining well, we are happy, US citizen, daily counseling to the child is doing well, and suddenly this happens.
So in which time was already in case of a heart disease, sudden heart rate of around 200 with perfusion being affected, relative hypotension, the previous blood pressure readings are normal, and along with hypoxemia. Hypoxemia itself, one can induce certain arrhythmias. Second, because of the underlying heart disease, there's a possibility of previous surgery, the possibility that he may have an arrhythmia. Third is some reversible causes like mistake, there may be electrolyte disturbances. All of that can also contribute to an arrhythmia in this syndrome.
So in this situation, will you give fluid? What will you do your first action?
I look at the monitor, I look at the ECG, and then see what next steps have to be.
You give the ECG.
So we suggest you of some kind of arrhythmias. So it's a supraventricular arrhythmia.
So your heart rate was 225 there in this
Yeah.
situation.
Yeah.
And like in this situation, also
So supraventricular tachycardia could be.
we thought of, and then we gave adenosine. By giving adenosine at that time, 266 for the heart rate. And after the first adenosine, there is a good response. The rhythm has come back to normal.
Yeah.
We try to correct the hypomagnesemia, other things which are there. And now again, happy, so let's have coffee. Sudden again.
So we can give it up to 3 doses of adenosine.
So it is sudden, that's an intention.
Hemodynamically unstable, right?
Huh?
Is hemodynamically unstable, you have shock texture.
Yeah, so that's it. But by that time we intubated also because here up till now we were not intubated. So we intubated the child, given the adenosine, and he reverted. He reverted in this situation, even hemodynamic instability in this patient, the rhythm. If you give adenosine that time, they may revert back. So may not require the cardio. If we gave everything ready, responded dramatically, there was a response. And then again it came second, then what happens is there are all friends to take opinion on. So we like and then it's a recurrent and they made us to talk to the US cardiologist also. So this goes on. So the life is never that time because of the shock and all those things we had to intubate. Up till now we were maintaining on HFNC, now we had to intubate the child. Saturations were good and this deterioration of the pulsation or the saturation was not because of the respiratory. It was the cardiac dysfunction which has caused the problem. Maybe of the fluid in that situation of the shock. So we stabilized and later on again extubated to HFNC that with rate. This worked. So they're not nothing yet. And now he became unresponsive, started convulsing. So initially respiratory, then cardiac, now CNS. So among it because of the viral infection per se or something else.
So it's very difficult to say here because the child is involving multiple system and the adenovirus is not only respiratory, it will involve from upper respiratory tract infection to LRTI, hepatitis and encephalopathic meningitis. So we just have to see the repeat copies of blood, so whether it is decreasing or increasing after giving a first dose of pseudophobia.
That comes to the question whether you require to do the quantification of the PCR to decide about pseudocopain.
Yes. So if you have very high viral load, then you need to give a pseudocopain in this kind of patients where the patient is deteriorating after giving an IVIG also. If we see the first dose of IVIG was given on the 17th, followed by patient second dose on the 19th, but still the patient was having the RTS and the fever persistent. And then we have given a first dose of pseudophobia. Before that, we did adenovirus PCR, which were around like 18 crore log of it, which is significantly very high. After giving the dose, the generally the protocol is to give after like 7 days next week. So after giving the first dose, the log has came down to food, but the RDS was persistent, and the child in between required intubation, bodicins, and all that. So, second dose was also Cidofovir was given, and after that, generally we don't repeat a log of Cidofovir, but the father was research office, and he was in a human wanted to do the PCR daily. So he was working on human genome project there in US. So being a scientist, he wanted to know everything, the numbers of study.
You can do a research, you can do a research by doing a DNA of my child about the PCR. So then we did it. So and what that question of does that PCR helps you in taking a decision? That is the my question. So we were forced, we were not like able to say no to him. My question here is when the PCR is when this law have there and it is declaring cardiac or something, and effects of the copies are increasing, whether that helps me to decide about pseudocode. That is my look at.
So generally we do every weekly and to decide regarding when to stop the pseudocode. So basically, in immunosuppressed patient, they will stop Cidofovir when the copies will go down below 1,000 or below 500. But if those are still the symptoms are persistent, there is no any proven protocol till how many days or how many weeks to give. So yeah, so after three doses, I think the log has been down to.
And then later on, we said, no, we will not do now because the patient has improved clinically. He was on the antitumors and amiodarone for the heart. All those medication and like a normal, and the X-rays has improved. And we subsequently, yeah.
Does the copy number correlate with clinical picture always? You may see copies coming down, child deteriorate, can be a macrophage activation. So copy going up, clinical doing better, then I may not do anything, right?
So basically,
it will take.
Yeah, so basically, Cidofovir is not studied in immunocompetent. So it is more of those post-hematological BMT where they don't have the T cells, where you need to see this because they can rapidly progress this thing. So immunocompetent is just people are using case to case basis. So you don't have any guidelines.
Such kind of cases that IVIG was the question, it is beneficial. If it is multi-system involvement and after acute phase is gone, so it is antibody dependent case, and that time IVIG is better than the infectious disease person can help me out in this, but as an intensivist, I will go for IVIG, such kind of.
That's what it is. And we have got influence that post idea is restore the problem. That's all. And then later on, this was the issue which was going on. And that's what I will tell the disease process was evolving. Now we'll come. This is the third case. We have time, 5 minutes. Yeah. So this is how the past wasn't told me about So this is a 10-year-old child like previously then brought to the complaints of fever for 5 days duration, high grade intermittent. Child had a the 15 days back had a viral infection, and mother had a similar complaint and was admitted at Jupiter only with entry. We thought it's an entry. So child was conscious. There were multiple petechiae on the bilateral lower limbs. Splenomegaly in the left hypochondrial region.
So child is conscious. Evaluated outside was thrombocytopenia. At least said that the child is having typhoid. So if child present with the thrombocytopenia is suggest of severity. And blood culture and other investigation was said. And
PS was showing the large platelets and 10,000 was the platelet count when he came to. So what can be the possibility? Yes. We know that this is mostly mother had an entry. We had a fever. We thought of it's an entry. So this and he had a big fatigue.
Okay, which drugs were given for as a treatment for
Which one?
drugs were given for the entry?
He was on the oral Pexim outside to start it, and then
That could be the possibility. Maybe resistant typhoid.
With machine count platelet or somebody had seen the screen.
We are waiting here.
Waiting here. India only.
Yeah, it's okay.
Localized.
Yeah.
Post infection ITP
Can we can malaria? So those are I'm not saying it is enteric. So this is enteric means mother had an enteric was positive. So we thought first enteric. It can be malaria. It can be dengue. But PTQ.
IPF was done.
Yeah, it was done.
So it is suggested to hemolyze.
Hemolysis.
IPF it means the occasional large platelet again and again you are mentioning.
Yeah. Yeah, but it was not the smear was seen.
What is the RBC count?
BC count आता हमारे में है.
But I can tell you, occasionally you may have low large number of RBC recurrent. So platelet may be counted as RBC for the counter.
Yeah, that was not the situation in this patient. That was not like
It's localized. Very good.
bone marrow is responding.
Yeah.
So that is the bone marrow. Smear is showing large platelet, bone marrow is showing. So and it is getting destroyed. On this was 21, 22nd it was 4,000 only platelet.
So it was the ITP post infection.
That is one of the factors. It's a post-infection ITP. That's what we thought of. So etiologic. So we thought of and we said malaria, which is negative, dengue negative, PS river large platelet, hypo micro, no evidence of hemolysis, and blood culture was awaited. So how should we proceed? Any other investigation? What treatment with antibiotics? Usually these questions come to our mind. What do you want to answer?
So with antibiotic ceftriaxone, primarily when the child is admitted with us, 70 to 100 mg per day per day. So that will be the treatment of choice. Apart from that, the thrombocytopenia is persisting, which is concerning. Though entry itself can present with thrombocytopenia, we need to rule out co-infections that we have already done malaria, then everything has been ruled out. But with the peripheral smear constantly showing low platelet count, we need to see whether there is some autoimmune also condition that is present because the child is around 8, 10, 11 years old. So there is we need to do AMA, we need to do BCT, all those factors also.
That came negative. That only the reports came that ICD came negative. So role of IVIG, that's what we thought of ITP. Role of IVIG in this situation, role of steroid. Mother is having any like habit right now within to no role of steroid, right? IVIG.
Apart from you, how the child?
He was toxic.
Any other system?
We had PTK, platelets are dropping.
There any other system dysfunction, active bleeding?
There was no bleeding as such, but suppose you now if I want to decide about the platelet count which is 4,000 and there is a PTK,
We do bone marrow heal.
bone marrow. Why you want to know bone marrow? What is the system you want? You want bone marrow culture? You want the IT to be HLH? You want for the malignancy? What do you want?
I think you are done already. How much?
So in this situation, what we did was give SDP at that time and was monocyte and azithro we gave. Thinking of monocyte ceftriaxone resistant and mother was admitted there with the entry and she had a stormy course. Before the report, we came to give this and this was the report. So it's a ceftriaxone resistant. So MDR, the ceftriaxone resistant, USG abdomen normal, rest of the things are okay. Enteric with thrombocytopenia was the working diagnosis with ceftriaxone resistant continued the azithro. So we how to proceed? What choice of antibiotic?
Choice over here is azithromycin. Most of those who are ceftriaxone resistant Salmonella type, they are sensitive to azithromycin. If MIC less than 16, then we consider azithromycin as sensitive. Second, we have cotramazole. We can use orally also. Third, if there is a multiple resistant, MDR resistant to fluoroquinolones, azithromycin as well, you can go with a meropenem and ticagrelor. So that should not be used routinely, but in severe cases.
If you see here, the ceftriaxone is resistant to salmonella is resistant to ceftriaxone, so basically it's a yes beer. But primarily it is sensitive to other primary drug like amoxicillin and cetera. Here I would go, the patient is having a low platelets with serious resting fever. I would go for definitely the melopenem because for years where it's a treatment of choice to treat initially with the melopenem. And you can also use the azithromycin along with. But single azithromycin generally we don't use in severe cases.
Yeah, we gave the platelet, there was hardly any rise, and it was resistant. And the IVIG also given, there was no response to the IVIG. And the platelet also, the post 1 hour consumption was 39, again repeat next day was the 14 or 49. Now look at the hemoglobin drop. Actually, she was the initially was used like a baby, right? So hemoglobin started dropping.
What about creatinine? What about creatinine? Normal. Urine output is normal.
Creatinine, 1000 something.
One, D1,
Sir, inject an enzyme.
urea.
So that's a problem we didn't involve Vijay this time. Huh?
Urea.
Normal. Blood urea nitrogen was normal, creat was normal. So hemoglobin was dropping to 5.2. Hemoglobin platelets are 18. And the count which was very high.
Even after SDP, immediately the platelets were coming down. Means it was some immunology, the platelets are destroyed.
So that's what we learned from the ITP. The moment you give the platelets on one rise immediately, give you infection maybe 6 to 8 hours. It's a DIC, the 24. Those three algorithm. That's what the thought process was. But still it is not rising, it's resistant and why? And the patient is not responding to fever. Fever was consistent initially.
Yes, sir.
Yeah, so that's what the thought of Vijay, HLH, malignancy, DIC, and thrombocytopenia.
सोचा लेकिन बुलाया नहीं so I thought I will margin at least here if not included. Logic. I would have still thought of creating upfront, but once I give IVIG for any disease, whether it's a TB or whatever reason, you will stop delivering the CBC. IVIG by rule can cause a lot of leukemia response. So the counts going up is irrelevant for me. Hemoglobin can definitely drop because of hemolysis. So IVIG commonest side effect is the TCP positive hemolysis for obvious reasons. You measure IVIG with so many donors and there is a cross reactivity. Third thing is obviously ferritin of 984. If three antibiotics don't work, I am okay even giving a 30 rupees of prednisolone. If not the entering HLH, it will definitely pull him out of the hemolysis that happened.
We need steroid, but only when we are entering, will you give steroids?
I will. Because you are giving three antibiotics.
We can give steroid. We can give.
I'll ask you, where did I quickly the pav bhaji from? Before giving the steroids.
Yeah, because there are a lot of cases that are around 180, 200 cases right now going on. And these are steroid, sorry, this ceftriaxone resistant.
In cases of those who are ceftriaxone resistant and those present with MDR, salmonella typhi, and if they present very sick and severe thrombocytopenia and shock, we can use steroid in high dose.
Shock is different. Shock, those are the steroids are different. I'm talking about the platelet which is low, and for that, why you want to give, or what you want to give the plate. Or I'm not talking about the, if it is VCT negative, ICT negative, and it's not in a shock, will you give steroids?
So role of steroid is very adjunctive or it is limited in steroids because you have any encephalopathy or shock, there only you can use.
Encephalopathy, there was resistant refractors, it gives the platelet. So platelet refracting is the consumption of the production, that's what we look at. We thought of bone marrow, like an examination, we asked them for steroids, but our hematologist was saying no. I am not saying smear any abnormality. Initially, I will not do a no. I was thinking of something we may yes, I'm going to so was there sensitivity to meropenem in that culture? Yeah, was it very fast?
Yes, sir. Yes, sir.
Sensitive to meropenem. Sensitive to meropenem. Much in the nice.
0.25.
And the LFT parameters are okay.
Yeah. So these now come up. ICT DCT negative. And now initially there was no histiocytes, and now she started seeing the histiocytes in the peripheral smear, which was not there. And now this histiocytes has started seeing it. Hemoglobin has started. Ready and ready was at least 194. It is high.
HUS and
So this persistent anemia, thrombocytopenia, cystocyte, elevated LDH, renal urine is normal, creatinine is normal, no hypertension. So that's how we thought of it's an HUS. There is some hyperangiopathy, anemia, thrombocytopenia, cystocytes which are there. And this and the low and the other part there is no renal involvement, obvious renal shutdown, react not rising. Think of whether it is the situation. That's why you can visit HUS. So typhoid induced HUS, there are two entities, typhoid induced HUS and cetotoxic induced. So these you can develop. So the no direct action mechanism, it's an endothelial, the immune mediated systemic inflammation, direct invasion with the HUS with the salmonella. Diarrhea not always prominent, may be present. Complement system possible in predisposed individual. And blood and stool cultures register of typhoid. They can cause renal injury directly with salmonella typhi, and cetotoxin has a different type of injury and can cause HUS. So this is the mechanism of pathogenesis of HUS in a salmonella typhi. So glomerular macroangiopathy with renal intravascular coagulation, which intravascular coagulation need not always be widely disseminated. Type or so-called disseminated vasocoagulation may be localized type. That's what has been described. Leukocytosis is the point towards development of HUS that they have mentioned in this paper. So leukocytosis, which was persistent there, and this they have the localized HUS or microangiopathy with anemia and all. So we were not convinced what to do in this situation, to whether in this situation to do a plasmapheresis when there is no renal creatinine not high, not the urinary output is not the so-called for health. So we took Madam Omali, what is Madam's opinion in this situation, and the other investigations came negative. And then Madam said, go ahead and do the plasma X-ray. We'll see how the response is. In this situation, when we did plasma, initially there was a little rise. After 3 or 4 cycles, then went on, the platelet went on increasing, the hemoglobin started maintaining well. After this, like 5 cycles with 1 plasmapheresis. Once it is started maintaining well, we started doing the alternative. We used to look at the hemoglobin drop, LDH high, PS semester of histiocytes. These are the markers to decide. The first daily for 5 days, then later on the hemoglobin, suppose it is dropping, LDH rising, then alternate day. Till that time, and then later on, hemoglobin started maintaining. White cells started coming up, platelets started improving, and then before and after, there was no histiocytes afterwards. So definitely, it can be a thought process that it is the typhoid induced HUS, which was refractory, which was not responding to IVIG, and this the other causes, and just responded to the plasmapheresis, and it was resistant. So there are papers which are we presented this type of scenarios. The case reports are there when we looked at. So we still were not convinced at that time. We still typhoid induced HUS or no. Whether there is a genetic background, whether infection, any other infection associated systemic endotoxin. This is just a thought process which we wanted to give So there are certain patients which are rarely renal injury also with an HUS. But here definitely has shown response and now he is absolutely doing fine.
Any point of time in this child you got a renal dysfunction?
So that's what there's a microangiopathy, anemia, thrombocytopenia, and there's an ICD acid
And we should evolve into some clinical problem.
So there was little bit of rise of BUN on the baseline. So what happens is here you wait till renal injury happen. To prove that has a damaged the kidney. That was the thought process.
You are not into HUS much better than what I understand, but you were seeing the HUS coming without the renal dysfunction.
That is the reason why we were not doing a plasma analysis. We are waiting till the time being given like in 2 weeks of illness, 3 weeks of illness. We're waiting till the time to bond our response.
Maybe God was almost over 2 weeks, which I can see even it can be a spontaneous. Why we are attributing that to a like the recovery which you got was almost over 2 weeks, right?
More than that.
Yeah, more than that. So whether it was a spontaneous recovery which could have happened with any other.
Why hemoglobin should improve?
Yeah, I don't have answer. Okay, but
why LDH should be higher?
The debate and
So that's the reason why.
The science. There are some things that
hemoglobin dropping, LDH going up, and there is a histiocytes virus to place excuse. So this was the positive for it was high at that time. Like I have not mentioned it here, it was going up.
But tell me one thing. Right from first slide, you have been always guiding or misguiding us on occasional very large sign.
That was the first slide. So that was the misguide to be always mind. So that was mentioned on this variable stair that we were thinking as a routine as an ITT, one of the factor, bone marrow suppression, HLH, these are the usual we think of. And when we started seeing this histiocyte, hemoglobin started dropping. So then there is a thought process, and actually we were not convinced to do a plasmapheresis. Then we talked, madam, and there is no evidence to do, but you do it. That was the thought process which was. Yeah, but that
What?
Yeah, it's yeah. So one does not switch on the toxic producing genes, and you don't have release of toxin like others, which cause an increase in production and predisposed to an HUS. So this was something which was different, and we were required for a one week.
One of the three cases is we are switching gears from infection to immunology. From the years, it won't be monsoon malaria, it will be immunological.
Fine. Time is over. But actually,
देखो किधर है नहीं नहीं क्लिक नहीं किया
नीचे होगा
हाँ ये
they promised me guided room right दूसरे जैसा ट्रीटमेंट देगा
ये देखो
नहीं नहीं
ये इसका इशू करो मुझे क्या हुआ कहाँ किसका नहीं है सब ये
ऐसे ऐसे because and मगर promise योगा टाइप ट्रीटमेंट 10 मिनट आपको मिलेगा और 10 लोग डेफिनेटली मिलेंगे Start talking about time challenge. Student is a bit wanting to sleep. Am I audible? Time is ago.
Is that working? Take the working one. That one is not. Go ahead.
So, only reason for this was Pavlov being a dear friend stops referring patients to me. The other thing is obviously I am the hard least working in monsoons. I wouldn't go any even to save my life on a Sunday. So I agree with this lady who says let's agree that during trains everyone should be at home, right? But there are mummies of patients who believe in all these things and they start discussing maybe my son's immunity is low, we should be the doctor, etc. And pediatricians, as always, are hardworking and they are always happy when it's raining, patients and others. So I thought I should just what is so I just touch upon dengue. We've been hearing a lot about dengue since morning. So TPP, as someone alluded to, and I feel that the pediatrician पिलाते रहता है पानी in dengue. The nephrologist निकालते रहता है, dialysis करो, plates करो, CRRT. And somewhere where do I fit in is probably I asked ChatGPT, which are two professions which Zuckerberg will not hire $200 million. He said a pediatric rheumatologist because you need people with artificial intelligence, not natural intelligence. Number two, which is the profession which will be least affected by AI? I said it is pediatric rheumatologist and a plumber. Because in the monsoons, I think I am the perfect plumber, or you would be better to utilize my services to plug in those leaks, praying that the leaks don't worsen and lead to end organ damage. So these are a few myths, and I always like to remind the pediatrician about a few things which I think is important. CRP negative, no HLH, no mass. Again, the same old ranting, but again, in dengue, it's a very peculiar situation where you may have CRP which is negative and you may still have a full blown HLH or a mass. Second, SGOT and SGPT equals dengue hepatitis. The session started with the Pada Vijay in the morning or the Chota Vijay in the morning who said dengue hepatitis is common. But as pediatricians, what I want all of you to write is an SGOT and an SGPT every time you start penning down your investigation charts, at least for the next 3 months. Because the kids, how many of you have seen dengue deaths? Other than Dr. Mohite and the senior guys, how many of the youngsters have seen dengue deaths in front of your eyes? Not many. I see 3 or 4 kids die of dengue every single year. And somewhere I feel that these kids would have given us enough chance. And the biggest trouble is like the California patient, even the Talagoda patient will have problem. कल तक तो अच्छा था, morning तक तो बोल रहा था, and the rapid worsening which happens in few kids like this. Ferritin, I always keep getting accused that ferritin तो सबका तो भेजता रहता है, भेजो और भेजा लगा के भेजो and then भेजा use करो कि whether how to interpret that. Not भेजना again is a problem because I show you some examples. And then the theories most get better. Yeah, pediatricians are blessed with good karmas. Many of us get better. But the 30% or 14%, if I remember it, in WHO, who went up with severe dengue, maybe the 2% who died, I think we owe a little bit more to these states. And the biggest problem is it's very difficult to predict, easily missed. And once you enter that day 5, day 6, day 7, you will find it very difficult to salvage them. So these were 2 kids who were admitted in Jupiter Hospital last year. In fact, there were 4 of them, but these were the 2 kids. Both were 6-year-olds, one admitted on day 8, one admitted on day 4. And then everything what we have been discussing since morning. One had a ferritin of 3,500, the other had a ferritin of 15,000. What was different was this was my own kid of a systemic GI who got bitten by a mosquito and ended up having altersensorial seizures. The phone call directly came to me, and he was dengue IgM and Vidal positive on day 4. Which kid would survive, you think? The 3,500 or the 15,000? Why is that? Which is a no-brainer because getting the child out of dengue
might be difficult. Getting the child out of HLH is slightly easier. And the good old rule in rheumatology is throw the kitchen sink when you are with this. The trouble is with these kind of values, and when those days Parmanand was kind enough to refer these kids to me. So 80, 350, 800 was happening at the nursing home, and this kid landed up in Jupiter with a ferritin of, with a SCTT of 2200. And सामने मेरा बच्चा है जो स्टीरॉइड पे 15,000 के साथ is happy, and this child is bleeding to death. So this child has given us enough time. But then that theory or that, I won't say casual approach, but not all daily hepatitis, 80 पे चलो 350, 800 is climbing up in front of the eyes, and you are wasting crucial time, right? So we talk about leaks and storms. There are enough. I won't take much of it, and there are enough papers which talk about warning signs. With warning signs, people have done documented ferritins on day 3 and day 7. This is actually an Indian paper from AIMS which says day 3 ferritin 513 with warning sign it was 1002 and severe dengue was 2352. And this was the same case on day 7. And then they figured out that ferritins of 1247 on day 3. Of course, these are statistical values, but in an ideal world, when you are really concerned or worried about you will have a clinical inkling as to which are the kids who are worsening in front of their eyes. There is definite merit in doing ferritin, right? So any child who's you guys see on day 3, day 4 of a febrile illness which looks dengue to your eyes, flushed, please react into this, but this has to be complete at least on the first day so that you can breathe easily. If this OTPT comes 100, 200, be on your guards because 1 to 2% may just worsen, and people who are placed with busy OPDs, please beware. And this is a slide which we've been seeing this since morning. Most of us know that NS1 ends here and antibodies start. None of this is going to cause cytokine storm. This is the phase, So according to me, where cytokine storm or cytokine release happens is that day 4 to day 6, where you will have ongoing leakage, you will have organ dysfunction, you will have organ damage, etc. So this is that critical phase of dengue where there is enough chance of a child to reverse back, right? Most of the, and as intensivist, you are worried that here you will pump fluids and in the reabsorption phase, you will end up with pulmonary edema. Somewhere in between, if you can do something to start plugging in the leaks, you might be able to save a few lives. And remember, why do I say the role of steroids is because we think that in dengue, it is like Kawasaki. It is more a strain than an endothelial damage. A damaged vessel will not reabsorb on its own. The very fact that what goes out comes in within 48 hours means that it's a cytokine-induced strain on the endothelial muscles. So, which is perfectly amenable to treatment, like Kawasaki disease. So when do I start thinking of cytokine release syndrome is when I have a combination of increasing leaks, and we talked about pulse pressure. Those are initial signs that this is a child who may need treatment. Liver injury, bleeding, and inflammation. When I see all the three, and I think people who long time back, remember we had discussed MISC on one of the podium. I use this word inflammatory coagulopathy. That's the best way to understand which is a child which is going to go into a cytokine release storm. And we skip this because we've seen this enough. Now, this is a bothersome part when it comes to dengue. Amol is there or Amol has left? Amol is on the way out. Yeah. And if you better get out of this room. Amol and Dhanya both, I think. Right? Because you need a good sarkar for balancing, whether it's the country or what is SIR is systemic inflammatory response and what is CAR. Last year, Pedicon, they gave me a topic. You have to talk on immunomodulation in sepsis. What do I do in this? And I remember reading that whenever there is a systemic inflammatory response, there is also a phase of compensatory anti-inflammatory response.
which means as much as I am worried about controlling the inflammation, I'm equally concerned that whether I'm pushing this child to the other end, making him prone to bacterial infections. And these two phases often coincide. So why do I say this? I will skip this, but I thought this is quite a general thinking that I have. How is dengue sepsis different from bacterial sepsis? I think dengue there is more of a leak which causes a shock, whereas bacteremia is more of vasoplasia. Dengue for some reason is more liver, whereas bacteria, like we discussed, is more alveolitis, pneumonitis, ARDS. Mesangial and glomerular is more in the dengue, possibly because of macrophage activation, whereas you see more of tubular necrosis due to thrombotic complications in bacteria. This is the most important. Negative CRP in dengue with life-threatening consequences versus bacterial infections. We are easily blessed with high CRPs. Many of the dengues which end up in trouble have because of low platelets, whereas I've seen quite a few infections with catastrophic APLA or prothrombotic complications. The last, sorry, I'm just going to touch upon ferritin because in dengue you will have to know what role does ferritin have. This proportionately high ferritin is sine qua non of dengue HLH, right? Nowhere else will you see such real high ferritin. We have seen high ferritins in a few cases of other infections, but this is a disproportionately high. And this is the most important slide. After this, I think you can stay for lunch. In dengue, there is hemolysis or someone is given a zealous transfusion. There is a lot of RBCs which are lysine and floating around. So the hemoglobin binds to the CD163. Remember, the macrophage is the main place where everything happens. So the hemoglobin binds to CD163, enters, and to bind heme, we know that ferritin gets released. Number one reason for hyperferritinemia. What happens along with it is the viral DNA in the form of DAMPs binds to toll-like 9 receptors, enters the macrophage, and starts activating what is called as an inflammasome. How many of you have heard of inflammasome? Quite a few of us. Right? So that's the protein unit which is responsible in throwing out the IL-1 family or IL-18 interleukins, which further starts triggering of the macrophages to throw out more ferritin. Now, what happens subsequently is this nice paper which says that along with throwing out IL-1 beta, which is causing all the HLH and inflammation, ferritin also starts releasing IL-10, which is the anti-inflammatory cytokine, which makes you wonder whether to immunosuppress or not to give steroids. Had Parmanand referred that HUS to me, I may have said, do a marrow, please take a gamble, give the steroid. Why HUS without kidneys? Possible. But in this situation, the message I'm sending you is always send a CRP with a ferritin. Why is that? Because we all know this seminal paper which says ferritin more than 10,000 is HLH unless proven otherwise. You may be interested in knowing what has caused it, but your job is primarily to save the life, number one. Second, should I wait till 10,000? No, because a 3,500 kid should not have died. And it's just that at 10,000, we are sensitized to throw in the kitchen sink, whereas at 3, will become 5, will become 15 in front of your eyes. The IL-10 story becomes important because, like I said, dengue is a CRP naive situation. I've tried reasoning or reading enough to why dengue HLHs don't mount a very high CRP response, but haven't come up with a reasonable answer. But there is enough literature to say that dengue HLH with high CRP has bad prognosis as compared to a dengue HLH with a normal or a negative CRP. And makes a lot of sense. The only thing is if I have a high ferritin with a high CRP, he is immunosuppressed and be liberal with antibiotics because you may be pushing this child to the other extreme. If I have a dengue with a high CRP, a high ferritin and a negative CRP, I may be easily doing what I normally do, which is increase your immunosuppression. So remember that ferritin is no longer an innocent bystander as far as dengue is concerned. It is going to escalate the cascade. It is going to come in a way of interfering with the inflammatory response. So logically, a serial monitoring of ferritin and the fever is often going to be helpful in knowing the recovery. In the HLH workup, I always recommend fever and ferritin comes down the fastest. So the best way to understand is, someone use a COVID analogy in the morning, and I think dengue is pretty much similar, in when COVID used to kill, or people say steroids, many people died because of steroids. No, the recovery trial said that if you use the steroid in the second half, many kids started recovering, and many adults, sorry. So if I use the same analogy that the viremic phase goes down, and that's the time when dengue also starts getting trouble, the judicious and the very cerebral use of the DEXA in the recovery trial and the solumedrol in our story, it might be a rational and a reasonable way to start thinking of immunomodulation or cytokine storm reversal. This is almost similar. That day 4 to day 6 is probably your best window in the few kids who we worry about. So quickly, the last 3 slides. When do I suspect as cytokine storm in dengue? Same. Go to that MISC slide and you will understand the same. Abdominal pain, bleeding, blood pressure on the lower side, CNS dysfunction, encephalopathy. Remember encephalopathy, mesangial cells, glial cells, Kupffer cells, osteoclasts. They are all macrophages. So you will have a child with dengue going into a altered sensorium could be having a cytokine storm or a macrophage activation in the brain. Respiratory distress, encephalopathy, and obviously bleeding in the presence of fever. Fever is very, very important. If there is ongoing fever for 4, 5, 6, 7 days in dengue, think that you may be dealing with a cytokine storm. And remember the same ABCD that we always used. You will use ALT, AST, antigens, antibodies for proving the etiology. You will document the bleeding tendency, the organ involvement in the form of a creatinine and enzymes, D dimers, LDH, ESR, ferritin, fibrinogen, and urine PC ratio. Remember to send all of them serially. Sincere request is कल का दाल आज की सब्जी आने वाले 6 महीने नहीं होगा. Send everything at the same time. Most important, HLH is a dynamic process, right? And when if it was in my hands, I think I will do all of them on day 4, just because that 1 to 2% of kids might decide to get worsened on day 4. And that's the time when they may actually come walking into your OPD, and that night time you may end up with a severe cytokine storm. So dengue with fever with inflammatory coagulopathy, think of cytokine release storm syndrome. And if I do what I do, what do I expect? Inflammatory coagulopathy. So easy. Inflammation, anemia, counts, CRP, LDH, ESR, ferritin, fibrinogen. And coagulopathy, you will know with dropping platelets, D dimers getting deranged, ETP, INR, often a prognostic marker. Last but not the least, organ involvement. It is very, very similar to the MISC thing that we said. Kawasaki plus organ involvement plus inflammatory coagulopathy is MISC. In a dengue, you will call this a cytokine release syndrome. And most of the times you will have antibody positive. Occasionally, you may have this overlap phase where you may have both of them. The last 3 slides. With steroids. So both of you remember this. What steroids? So methylprednisolone is the go-to drug. It is a potent mineralocorticoid, works quickly, and it gives no 2 or 10 or 30 in this situation, right? I'll probably discuss this over lunch because most of us know the non-genomic versus genomic action. 2 mg ki 10 mg ki 30 mg, correct? If I want quick action, I will use the non-genomic, which is 30 mg per kg pulse. If I want a slow action, you may probably put this kid on the 2 mg per kg once I get this child out of trouble. Dexamethasone, long acting, but takes a while to act, better blood-brain barrier penetration. So it may come handy after you pulse the 4 or 5 doses, right? Now, this is one thing which I want all of you to take home to wherever, which hospitals you work. Remember, there is this, the John is there, perfect time, and Parmanand is still there. The cytosol, which we talked about, the filter costs a lakh of rupees. Cytosol filter costs 1 lakh of rupees, and I can get 100 injections of anakinra for 1 lakh rupees. The issue is cytosol is easily available in Jupiter Hospital, whereas anakinra has to come all the way from Germany. It is like Xerox. If I mangao one, it costs 10,000. If I mangao 1.5 lakh का 5 डब्बे मिलते हैं सर. अभी पूछा मैंने सीक्रेट है. Hey, where there is a Gujarati in Ghatkoper, you can arrange many things. हाँ? मुझे बोला ऐसा 1 रुपये वाला 1,000 वाला किट नहीं है. किट नहीं है. नहीं, वो biosimilar is not there. That's the problem with Sobi. They have not tasted according to the copy, right? Say 1 lakh 100. People do pay. So the drug of choice, anakinra is the drug of choice for polyarticular GI, which people take daily. So 1 महीने का 28 सुई लगता है. 28 सुई तो 1.5 लाख में वो 5-6 महीने का डब्बा देता है वो. पूछा तो it's about how good are your bargaining skills. I can't bargain because this is going to take 20 or 30 injections to save his life. But for that we have to do a lot of jugaading at least my hospital. But then we've seen one kid come out of trouble. We've used it on various other indications. And this is something which I think hasn't been touched since morning. The role of immunomodulation in not just dengue associated HLH. Remember rickettsia, remember mycoplasma, for example. Many of these kids end up with trouble with HLH like situation. And it is available. It has to be used very safely and quickly. And IVIG, we discussed it enough. Oh, sorry. People should watch this movie. If not, I read this article. Right? How many of you have seen this movie called Lazarus Effect? Not on Sunday, It's a nice movie where the male and the female counterpart, they devise a new medicine which apparently gets dead people alive. So, and they develop this serum which can get the dead alive. And as it turns out, the girl gets electrocuted and she dies. And the same potent serum is used on this girl to revive her. She comes back alive, but then she does crazy things like, that, which is a Marathi movie, that Mana Udanavara. She starts hearing female voices. I forget the name. So this girl, girl behaves badly, she introduces murders her boyfriend, and so on and so forth. But that Lazarus Effect means just miracles to happen. And this is a nice article in the Lancet of a 9-year-old girl who had non-familial HLH developed the worst of fungal septicemia. And ferritin was 1,92,549, ESR was 1. I think the only person with ESR of 1 in this room is me. My ESR is always 1 for some reason. But then this was a child who was on a death warrant. They had signed a DNR for this child. And then they sought its inspiration from fires, subarachnoid hemorrhage, so febrile inflammatory related epilepsy syndrome. Anakinra seems to work. And they started, जाना ही है तो anakinra देके भेजते हैं. They started with 2 mg and went up to 12 mg per kg, flat EEG, MRI changes, and they almost discussed withdrawal of support. And then they said, let's jack it up to 48 milligram per kg per day. And this time, within 48 hours, made a dramatic recovery without any major neurological insult. It proved two things. A, that anakinra does work because it doesn't just targets the involved cytokine, if I may use the word, because IL-1 is just the start of the whole inflammatory cascade. Second thing it proved was its safety profile. More than the logistics, what is reassuring me about this drug is it is extremely safe to be used in a lot of bad fungal sepsis. So when you're worried about that high ferritin and high CRP situation, anakinra again, quick in, quick out, half-life 4 to 6 hours. So in that, so while dealing with the Dr. Parmanand's daily, we were faced with the situation, anakinra देके वो cytosol करेगा तो क्या फायदा? Anakinra भी निकल जाएगा. So you have to time that drug in such a way that that doesn't get washed out. And that low, the short half-life helped in, coming to that conclusion that you obviously couldn't use tocilizumab with such fulminant hepatic failure. So anakinra is the word I think all of you should remember, and I'll give you the number of that guy to manually profile for all of us. So safety and efficacy has been proven, and this is probably the only paper on dengue HIV written by a rheumatologist from Calcutta. So we talk about beta and prednisolone, etc. You don't need to follow the HLH 2004 protocol. Quick paper of 2 to 4 weeks should be good enough to treat these kids. I'll skip this for want of time. And I think over time, we are going to see a lot of AI and personalized medicine. What are the drugs? There are a lot of drugs like we know now, anti-malaria is in the pipeline. We have specific cytokine blocking agents. We have these IF and gamma blocking drugs, which are officially being licensed for treatment of HLH in rheumatological conditions. IL-18 blocker, we know that EBV with B cell activation will respond to rituximab. With T cell activation, you could use cyclosporin. I haven't mentioned JAK inhibitors, which are the new things which can be used in many of these cases. What is most important is the timing and monitoring, right? Don't say कि ferritin आएगा ज़्यादा, LGBT आएगा ज़्यादा, because I think none of us are good clinicians or none of us have the time to be better clinicians. We are busy with so many things. ऑब्जेक्टिवली साबित करो कि रिपोर्ट फेरिटिन 5,000 का 15,000 का तो बच्चों को दिखेंगे हम लोग. I am not criticizing or sounding cynical. I lost one kid day before yesterday. One more proven systemic GI ends up with 6 episodes of loose motions, gets picked up on the right time. Ferritin comes 5,000, goes to 19,000, turns hepatitis A positive. HLH with 3 doses of steroids comes back to 1,000, still dies. So I could probably reverse the HLH, but I couldn't save him from the hepatitis A part of it. The drug which could have come handy would have been anakinra, because that may not have messed up with the hepatitis A. And somewhere I think in the process of blocking IL-6, I ended up flaring up the hep A is one way of thinking. But the other way of thinking is tocilizumab itself would have caused fulminant HLH or the hepatic failure, which is a known side effect. But whatever it is, it's when you start seeing deaths in known etiologies, then you start feeling a bit of a pain, right? So remember, day 4 is your time, day 3, day 4, and this is just one center in southern India which follows that when you have any of this, you start thinking of immunomodulation on day 4. If a child has needed more than 3 fluid boluses over 3 hours, there is severe lactate, ferritin is more than 5,000. These are situations where you may follow this sequence or you may do an IVIG, steroids, anakinra, possibly while you arrange anakinra. Please cover them with antibiotics. Taxane transfusions, I have a bit of an apprehension to you may end up causing more trali, etc. And remember, more than 50,000, etc. obviously needs a specialized center like Permanent and Vijay's unit at Jupiter. Please refer all the kids to me from tomorrow. So just a take-home message. When do I suspect CRS? Think of sensorium, shocky, leaks, persistent, systemic inflammatory response, bleeding, etc. Document the full work of the ABC that
we all known to. Please document hyperferritinemia, steroids IVIG anakibra or anakibra IVIG and or steroids. Keep this handy or keep a friend handy. And then hopefully we should be proactive and not reactive. So last slide, I promise. This is what dengue will look like on day one. Day two, कॉन्फ्रेंस में है मोस्टली ठीक हो गया डॉक्टर मोहिते चले भी गए now the day 3 day 4 is my big problem the problem for me is because patient चला गया लेकिन मेरे पास आया and then I call the pediatrician he said मेरे पास टाइम नहीं है वैक्सीन लगा रहा हूँ जल्दी बता and if you miss this you will end up with this is a point of no return. I do not have any political affiliations. I just want you guys to be a bit proactive. Please start doing some things, and if you see some things not behaving the way it should be, try to just think a bit laterally, and you may end up finding yourself and your kids handle. Thank you very much.
It's 2 minutes. Please wait.